Dear esteemed colleagues, dignitaries, and friends, at the outset, please let me thank Professor V.R. Rao Garu for convening the panel titled Anthropological Perspectives and Relevance in Prevention and Control of Sickle Cell Disease in India. The panel is submitted to the World Applied Anthropology Congress 2023, and we are so happy that it is going to be held at my alma mater, the University of Kansas, where I did my PhD program. And this WAAC 2023 is organized by the Anthropological Applications for Humankind. And the focus of our organization is anthropological knowledge to address human problems. And the panel, it quite nicely fits the theme of our Congress. And a major objective of this panel is to discuss strategies on impact evaluation of ongoing sickle cell disease prevention and control programs in various parts of India. And at the, I'm very thankful to Dr. V.R. Rao. I have known him, since 2004. We have been, since then, we have been actually collaborating. We published a paper recently, and we are working on a couple of other papers, I'm really honored, to welcome you all to this panel discussion. And of course, there are so many people here. I will go one by one. And first of all, I would like to invite Dr. Vinita Srivastava. I think, she is not here yet. And she's an advisor, Tribal Health Affairs, Government of India. And very hearty welcome, sir. Dr. D.N. Murty Garu, former advisor, Tribal Welfare, Department of Andhra Pradesh, India. And I think, Professor Graham R. Serjeant, he is going to join us soon. He is a former director, MRC Laboratories, University of the West Indies. And hearty welcome to Professor Pradeep Kumar Patra, Dean of Chandulal Chandrakar Memorial Government Medical College, Durg, and former Director General, Sickle Cell Institute, Chhattisgarh, Raipur, MP, India. And of course, Dr. Jene, Deepthi Jain. We are very happy to have you here at this panel discussion. Dr. Jene is, former professor and head of the Department of Pediatrics, GMC Nagpur, and also nodal officer, PMOCSIR Sickle Cell Project, India. And Dr. Suman Jain, a hearty welcome to you. Dr. Suman Jain represents the Thalassemia and the Sickle Cell Society, Hyderabad, India. Dr. J.S. Arora, hearty welcome. And Dr. Arora is the National Thalassemia Welfare Society, Delhi, India. He is from that organization. Dr. Nandakumar Menon, Ashwini, Godalar Adivasi Hospital, Gudalur, Nilgiris, Tamil Nadu, India. Sir, hearty welcome. Dr. Ajdi Italia, ex-Honorable Director, GO and GO Sickle Cell Anemia Control Program, Government of Gujarat, India. Hearty welcome, sir. Dr. Jyotish Patil, a super specialty hospital for sickle cell, South Gujarat, India, sir. Hearty welcome. And Dr. Kapil Dave, Seva Rural Hospital, Jagadia, Bharuch, Gujarat, India. Welcome, sir. Hearty welcome. And of course, there are so many people here. And Dr. Roshan Kola, we are honored to have you here as part of this panel discussion. Dr. Kola is former scientist, G and director in charge in ICMR, National Institute of Immunohematology, Mumbai, and member research advisory committee, ICMR, Center for Research Management and Control of Hemoglobinopathies in Chandrapur, India. Dr. M.B. Mukherjee, we are honored to have you here, sir. Former scientist, F and consultant, ICMR, National Institute of Immunohematology, Mumbai, India. And of course, we are really honored to have some anthropologists here. I don't think, Dr. Professor Saraswati Garu is, she's there. We are honored to have Dr. K.M. Saraswati, Professor, Department of Anthropology, Delhi University, Delhi, India. And Dr. Bhaskar Urade, Superintendent Anthropologist, Anthropological Survey of India, Nagpur, India. Dr. Urade, welcome. And lastly, I would like to thank Dr. G. Pedrataya Gadde. He is the General Secretary of the Anthropological Applications for Humankind.
Voice.
Actually, Anthropological Applications for Humankind, they are the people organizing the World Applied Anthropology Congress 2023 at the University of Kansas. I also would like to thank Dr. Narayan Reddy Garu, and he is the president of the same organization. And Dr. Narayan Reddy and Dr. Pedrataya, they are the two main forces behind, this entire scenario, organizing this conference, at my alma mater, University of Kansas. First of all, community engagement is very, very important. Really, it's a true honor to have two mothers of sickle cell warriors. Community engagement is very critical to the success of any scientific investigation. You all know that community engagement means treating the participants or study participants as equal partners in doing research. So I take this opportunity to invite Mrs. Jaya Sampath Ramteke, Sickle Cell Society of India, Nagpur. When we talk about sickle cell, we should always remember the solid contributions of late Sri Sampath Ramteke, who has he had contributed tremendously, especially when it comes to awareness of the disease. I would like to request Dr. Rao Garu later on to say a few words about him. As you all know, Ramteke ji, he was conferred, with Padma Shri Award, one of the prestigious award, given by Government of India, and he has done extraordinary work. And it is highly gratifying to know that Mrs. Jaya Sampath Ramteke is taking forward the mission and vision of Ramteke ji. May Ramteke ji, soul rest in peace. And I'm definitely, I would like to ask Dr. Rao Garu to say a few more words about the late Sri Sampath Ramteke ji, okay? And lastly, and I would like to thank Mrs. Preeti Nagrare, an advocate of sickle cell disease in India, working with Sickle Cell Society of India since 15 years, and both Mrs. Jaya Sampath Ramteke and Mrs. Preeti Nagrare, they are wonderful mothers, with the children that have this particular disease, and they have been in the forefront of, the awareness programs, and we should be thankful to both of them. And lastly, but not the least, Dr. V.R. Rao Garu, Dr. Vadlamudi Raghavendra Rao. I know he's a very well-known anthropologist, scientist. I have had the privilege of working with him directly. He's a fantastic scientist, one of the few scientists that have been doing a great job in India. I'm really honored, to be working with him since 2004, Dr. V.R. Rao, and thank you so much for inviting me. Of course, he was at various institutions. He worked, tremendously at various institutions, focusing on the biological, anthropological perspectives. Okay, lots of research he has done, and he worked as, in charge director of the Anthropological Survey of India. After that, he was with the University of Delhi Department of Anthropology. And, lots of jobs he did, with ICMR, Hyderabad, he is currently Dean Research Genome Foundation in Hyderabad, and he is also a visiting professor at the Thalassemia and Sickle Cell Society, Hyderabad. And Dr. V.R. Rao Garu, I cannot tell what you have done to this field within 5 minutes. I'm honored, truly honored, to be here, to be part of, this panel discussion. Thank you so much, sir. I hope I have not missed anybody here, right? And of course, it looks like Dr. Vinita Srivastava has just joined us, and Dr. Srivastava, she is an advisor to the Tribal Health Affairs Government of India. Ma'am, hearty welcome to you, and we are honored to have you here as part of this panel discussion. Sir,
thank you so much.
You're welcome, ma'am. Dr. Rao Garu, it is left to you now.
Now that we can go with presentations one by one.
Okay. The first presentation is by Professor Graham R. Serjeant, is here. I'm not sure.
Graham Serjeant has not yet joined. We can go with Mr. Murty.
Dr. Murty, you are welcome to give your talk now.
Dr.
And let's please try to stick on to the timings, okay?
all the presentations is on my screen, but I am unable to share the screen. Host disabled participant screen sharing. Host, Dr. Bedrataya.
Oh, yes, sir. Yes, sir.
Please.
Yeah, done.
Done? Okay.
Yes, sir.
Now I'm sharing Murthyji's presentation. Yeah.
Sir, good evening, sir.
Good evening. Wait, sir, 1 minute. I practiced this sharing. Quite, yeah.
Dr. Rao Garu, can I have 1 minute, please? I missed it to say something. Okay. I think, many of you don't know about me. My name is Ravindranath Duggirala, it's fine, Rao Garu. It's fine. Let me introduce myself. That's quite fine. I did my master's in human genetics at Andhra University, India. And I came to the United States in 1986. I did my second master's in anthropology. Then I did, my PhD in anthropological genetics at the University of Kansas. Since then, I have been working in the area of statistical genetics and genetic epidemiology. My entire career has been focused on genetics and genomics of complex diseases like diabetes, obesity, and heart disease. I have been continuously funded by National Institute of Health since 1998. We have several ongoing projects, humongous projects, funded by NIH. My entire focus is on complex diseases, diabetes, obesity, heart disease, gallbladder disease, things like that. And I'm also so happy to inform you guys that, for the last 4 or 5 years, I have been collaborating with, 4 institutes, medical colleges and universities in India, focusing on genetics of type 2 diabetes in Indian populations. Currently, I'm working as a professor in the Department of Life Sciences, Texas A&M University, San Antonio. That's my brief introduction. Thank you.
Thank you, Professor. The slide is visible?
Okay, sir. Sir. Very clear, sir. Sir, good evening, sir. My name is D.N. Murty. Is a really 40 years of service in the tribal area mainly, and also designed education projects of Sarva Shiksha Abhiyan, Janashala, School Health, RBSK, RKSK, and Tribal Health, Adivasi Arogyam. These are all my projects, own projects are designed and implemented in the state of Andhra Pradesh. Now, I am also main priority is eradication Dolly deaths and thalassemia and sickle cell and medical plantations. These are main projects, sir. Now he is working in the Andhra Pradesh, sir, from Vijayawada. Sir, the tribal area of Andhra Pradesh, 27.5 lakh tribal communities, sir. Sir, next slide, sir. Slide, sir. Rattaya garu.
Yeah.
Please change the slide.
Yeah, please.
Next slide, please.
This is a PDF. What is happening? Yes.
Sir, this is a scenario of the Andhra Pradesh. Mainly the main district, Allur Sitaramraju district, sir, remote area. The main ITD, Integrated Tribal Development Agency of Faderu, Rampachodavaram, Chinturu. Population is the highest population. Difficult sickle cell disease is the top priority, sir. The state first district is this is, sir. Mainly sickle cell is treating 2 lakhs students here, sir. Thalassemia also there, sir. But whatever it may be, the highest population tribal is 6 lakh above is Allur Sitaramraju. The next is Parvatipuram district, and third one is Srikakulam. Really, sickle cell highest focus in the near Orissa border tribal area, Srikakulam, Paratipuram, Paderu, Rampachodaru, like that. These are my focus areas, sir. Sir, next. The tribal welfare residential institutions are here, sir. Total hostels, all the students up to 12th class, the residing here, studying up to 12th class. We started the testing also turbidity. There is a solubility test, and HVLs also conducting these schools first priority, sir. Next. Sir, we started in the daycare centers also. The remote area of Sitampeta, Paderu, Paratipuram, Rampachodaram, 4 daycare centers are sanctioned by the government of Andhra Pradesh, sir. Now treatment, screening and treatment is going in the other places, sir. The daycare centers are working in the control of the Andhra Pradesh government, sir, Tribal Welfare Department and Health Department jointly. Okay, sir. Next. Sir, this is key note, sir. Here, each district, one DASC, District Early Intervention Center, is under National Health Mission is established in the tribal area and plain area also. Total in the Andhra Pradesh 34 DAICs are functioning, sir. Main role is newborn screening, sir, at the time of delivery also. Yeah. Next is the new screening HVNC, 6 to 5 years Anganwadi centers. All schools in the state 5 to 18 years, and also capacity building and trainings, everything is the unit, sir. This is not a hospital. This is a unit of referral management, create awareness and capacity building, sir. The total everything is a data management also here, sir. Referral management is a follow-up also. This is one unit, sir. Is now in the 34 are functioning in the Andhra Pradesh, sir. Next. The HR, the District Early Intervention Center, total 18 is the members, sir. The medical professionals are there, paramedics are there, non-paramedical, medical, and non-medical also working, sir. Sir, just Rataigar konja paiki vellali. Here, each DAC, one manager also there, sir. Is a collaborative and a coordination to the other line departments, sir. The tribal SS last DS manager is the key role, sir. Here is a total coordination to the other department also there. The services of the DS is next. Thus, this is very important, sir. The DES is to provide total services, sir, medical service, dental service, occupational therapy, physical therapy, psychoideology, speech, vision, health, retinopathy, prematurity, nutrition, social work, special instructions, transport, and OVP system. Out-of-pocket expenses for poor of the tribal community, coordination, referral services, the training, everything is the 18 services, the main role, sir. The supplement services are here, sir. The disability certificates, special education services, aids and apprentices, training and rehabilitation, family support services. The main role is the then departments. Then means THEN, T, tribal welfare, H, health department, means NHM also, E, education department, means Samagra Shiksha also, women nutrition, women development, child welfare, Sampurna Poshana is also in the Andhra Pradesh, sir, inclusive education also there, sir. These are everything through DAAC. Now 34 are launching in the Andhra Pradesh. It is a unit of all departments, sir. Next. The general screening, 6 Ds, sir, total 6 Ds. The government of India National Health Mission, 4 Ds in the RBSK, Rashtriya Bharat Swasthya Karyakram. But in the tribal area in the Andhra Pradesh, we designed 6 Ds. The 0 defects during pregnancy. First, next defects at birth, deficiencies, diseases, development delay and disabilities, defects at adolescence. These are total 6, total 45 conditions are identified in the remote and screening in the areas of Anganwadi, schools, etc. The number 1 defects during pregnancy, total 6 conditions, sir. These are total 6 conditions in the first D, and second differs birth conditions is the just a minute, sir. 10 is differences birth conditions identified, and the third is deficiencies 5, and diseases 6, development delay and disables 10, defects adolescents 8. Total 45 conditions identified. These are all screening the medical services, medical and non-medical jointly. This means health department and education department, the schools, health department and women development department in the Anganwadi centers. The teams are arranged in the mandal, means blocks, and the primary health center wise. They are visiting every habitation. They visit to Anganwadi and the school. The head to toe screening will conduct in the children and the students also, sir. Next. The general, you know everything. We are testing here solubility test, next of test. The solubility or turbidity for the purpose of the sickle cell, the positive HVLC. The thalassemia area, Nestraf and the positive HVLC. This is continuing the Andhra Pradesh, sir. The last up to December 22nd. Later in 2023, one change is also there. Motto and the national changed the strategy also, sir. Next. The main policy system, it is first in India. The 9 IT days in the tribal areas, in the area of Andhra Pradesh. The ITDA level, one IAS officer headed by the all ITDA, and the control of PO project officer ITDA, health department, HLD, the DEAC, and the travel department DD travel welfare, the education, the PMRC, and education DU also, district education officer there, women development officer, the SHERP, APD, additional project director, NR is APD also there. These all are one team, sir, collaborative. They are under control of project officer is the IAS officer. Same way, Mandal, Primary Health Center, Grama Sachivalayam, it is also one like Panchayat is also there, Andhra Pradesh. The name is now is a government estate, Grama Sachivalayam. The main habitation. In the habitation, total tribal area in the Andhra Pradesh, 16,156 habitations are in the AP, sir. These are tribal habitations. Every habitation, Anganwadi schools are functioning, sir. The habitation also there, sir. Next. Is a government, the 2019 is a good.
Wind up chestara, time extra.
Yes, close. It's in 1 minute. It is a GO, sir, the first gym in India. The thalassemia, sickle cell positive cases, pension is a medical pension is 10,000 per month. This now 3,446 disease pensions monthly, 4 to 5, 45 crores per year is going to the pension, sir. Next.
Thank you. Yeah.
Sir, this is now proposed. We are planning 27.5 lakhs of tribal community. The POC test is will continue to 2023 and 24. Each 100 per head is proposed by the government of India to sanction the state government. Remaining amount is the state government. We proposed, sir, that approximately 30 crores required to this year, sir. Next, last. It is also a pilot project is the treatment, sir. Pilot is continuous in the JATU, Kakinada, and entire health university. Both are prepared plans, treatments, sir. Next. The medicine also, within June 15th onwards, we are planning to launch this pilot, sir. Next. The already Commissioner Health and Family Welfare, Director Child Welfare, Oils Department, ICMR sanctioned the proposal, sir. Sir, next. It is a medicine process. It is a counseling plan. Every ITDA was a resource persons identified. All the departments, they are the key resource persons to create awareness. IEs also. Next, last, close. That is my area, sir. This is a remote up to 4 kilometers to 30 kilometers by walk only to visit the tribal remote habitation. Thank you, sir. Thank you.
Thank you very much, Murty garu. In the
Sir.
lack of time, we will take up discussion after all presentations. Okay.
Okay,
Now,
thank
may I
you.
invite-
And
Yeah.
the next speaker is Professor P. Pradeep Kumar Patra. And please let us try to stick on to the times given the time constraints. Thank you.
Yeah, thank you very much. Am I audible?
Yes, yes.
Yeah.
yes.
Yes, sir.
Yeah, I'm really grateful to Professor V.R. Rao sir and Professor Duggirala sir. And I'm thankful to the World Applied Anthropology Congress that they give chance to me to share my data and my experience in the sickle cell. So basically, I work in the Chhattisgarh. It's in almost not a very old state of our country. It is on 1st November 2000. It came to the existence, and I started a sickle cell work here in Chhattisgarh 2007. And actually, I started work on sickle cell since very early in 1985 when I was an MBBS student. Professor Graham Serjeant was there in my place, and Professor Kerr, BC Kerr, is no more. And my focus in the work is the school-going children, though I have done some prenatal work also. But my focus in the school-going children, 3 to 15 years of child. Next slide, please. I do in my team actually consists of counselor, technician, driver, and some assistants. They go to the very remote place, and the basic purpose of my screening work I started in 2007, funded by the state government, that is the Chhattisgarh government. So that time, that point of care testing was not there. The solubility test and the electrophoresis cellulose paper electrophoresis test combining I was doing. And my purpose is to detect the load up in our area and to create awareness, and the homozygous patients has to be that available treatment to be available, and the marriage counseling for the heterozygous pair. So the wonderful thing I got, the achievement is, initially I started work in 2007, they were preventing, this is due to the social stigma, they were preventing me to go to their village, to area, to do the sickle cell screening. But gradually, now they are calling me. So this type of awareness I could develop through this project. And the social leader also. I create awareness among the social leader for the marriage counseling. As you know, the social involvement is very important, as in the introduction, Dr. Duggirala sir speak, that the social leader, I involved them. So the marriage counseling part also they took part. They take in charge, and gradually the individual, the parents, the boys and girls, the marriageable as boys and girls come to me and that tell doctor whether I can marry or not. This is the awareness. This is my satisfaction. Next slide, please. This is the within 10 years, almost 17 lakh of population, the school-going children I screened, almost 10% is their gene frequency in my place, and 0.4% homozygous patients are there. All the homozygous patients are registered, they are regularly followed, and they come to our place, and our people also go to there. They are given folic acid, regularly follow up that and hydroxyurea, follow up mean the CVC, that KFT and LF. Next slide, please. This is the, because one peculiar finding, usually in the tribal population, you will find more sickle cell. But in our place, the OBC category, the Sahu, Kurmi, they are the more prevalence is there. Yes, ST population, this Adivasi population is there next to it. So this is the very peculiar finding in my place. Next slide, please. And this huge load in our place, so we organized an international meeting in 2010 that we're proud to have the Bharat Ratna APJ Kalam as the chief guest, and they are the concept camp, this comprehensive sickle cell to be started in our place because the huge genetic that the frequency is there, sickle cell. So we established Sickle Cell Institute in our place. This comprehensive care from screening, providing counseling, genetic counseling, marriage counseling, providing treatment that folic acid, hydroxyurea, and regular follow-up. And if needed, they had to be advised to attend the higher center for the bone marrow transplant. Next slide, please. This is the counseling material is provided to our patients, and the social leader and the policymaker also, both bilingual, Hindi and English. Next slide, please. And this I was telling you, the Sickle Cell Institute is there in the Raipur, all the revenue division, the medical colleges and all the districts are covered. They are linked with the Sickle Cell Institutes. So there, the sickle cell screening and the counseling is given, and also the hydroxyurea and folic acid also provided there. So, and the awareness part also, those with difficulty they face, they refer to the Sickle Cell Institute, and all the medical colleges, they are taking care. Next slide, please. So that is I want to share, and thanks. So that I think I am within the time. Thank you, sir. Thank you very much.
Thank you.
Thank you, Dr.
Prof.
Patra. Yeah, we are very thankful to you. And our next speaker is Dr. Bhaskar Urade.
Dr. Murade.
Thank you, sir. Thank you so much.
Yeah.
At the outset, let me thank the organizers for giving me opportunity. This is from Anthropological Survey of India. Since I have been working in this field particularly from 1992, when I was a research scholar working on the leprosy and sickle cell anemia. And it was Professor Rao, when he was the director in charge, transferred me to Calcutta to take up this project, this prevention of prevalence of sickle cell anemia in central India. We did many community health camps, and we did a mass screening at the community level in different places of Maharashtra, Chhattisgarh, MP, and we covered more than 25,000 unrelated individuals where we applied solubility test. Then, since our finding is, we found this sickle cell anemia present in the higher caste, middle caste, lower caste, and tribal groups, though the frequency varies from community to community and also from region to region. Next, please. Next slide, please. Next slide, sir. These are the findings that what we are harping more on. How best we can try to minimize the frequency that is prevalent among different communities. The earlier study shows the quite high and alarming situation among different communities in central India, but in our study, because of this awareness program that we spread, that we offered the genetic counseling program, we distributed genetic cards, and we referred the carrier couples to different organizations for prenatal diagnosis like ICMR, AIMS, and some IVF procedure also. Some families they underwent in Bangalore to have a normal baby. So our impact of this distribution of genetic cards and spreading awareness program, offering genetic counseling, this particular program helped the society, and the society was sensitized, due to which the frequency of the sickle cell has reduced for the last 20 years. That what data we have right now with us for the last 40 years, and that especially among the Pradhan, where the frequency was quite alarming, that is beyond up to 35 to 40% was there. Now that frequency has reduced drastically. So far is in the case of Gond also, and Mahar, particularly lower caste, that is scheduled caste in central India. Earlier the frequency was around 22%. Now that has reduced to 11.81%. That is just 50% reduction of the frequency has taken place during the course of time because of this awareness program. I would like to refer some case studies I have referred. So how this career couple, they took their advantage of this genetic counseling and this awareness program, that they become sensitive, and they themselves came to our lab to know their sickle cell status. So this is the impact of this our program that we launched in 2005, and this
Hello?
Yes,
something
yes,
went wrong, sir.
yes, yes.
Yeah.
Dr. Murty, time. Yeah.
The woman, after having 2-3 miscarriages, when the couple approached me, and then I advised them, I offered them genetic counseling. They went to ICMR. Dr. Kola is there. She is there. She must be knowing this thing. I used to refer many patients from central India to ICMR, AIMS, and some other hospitals. I would like to have one paper here that a 20 years old boy approached me to know his sickle cell status when he did not get proper response from the government medical college hospital, Nagpur, and a private hematologist at Nagpur, that is Dr. Ganju. After subjecting his sample for capillary electrophoresis, we detected that the person is carrier for sickle cell gene. So what we did, we offered mass screening at community level. For that, we applied solubility test. After that, we went for electrophoresis. After that, we did HPLC. After that, we did capillary electrophoresis for confirmation of the sickle cell or disease or trait. Then we went for DNA extraction, DNA study. We distributed genetic cards. We spread awareness program, offer the genetic counseling, and refer the patient, the patients, careers to different agencies. Next, sir. Last slide. Last slide, sir.
Yeah, you can 1 minute. There's some
Yeah.
problem. This is the last slide.
Sixth one.
Yeah, that is the one.
That is the one,
It's
Baba.
there, you know.
Yeah, Dr.
No,
Murty.
last one, sir. Sixth one, sir. Sixth one. Remedy. That is sixth one.
It's there, Dr. Varade. It's there
Yeah,
on the screen.
hence, Sir, hence this, our approach is human-centric centric approach. That whatever we are doing, the
Some audio problem.
Yeah.
some problem is there.
Dr. Urade,
Yeah,
can
yeah.
you hear
Please.
us?
So
Okay.
our main approach is, main concern is we have to serve to the mankind. So our remedy should be a human-centric approach. Hence, the early detection and an appropriate referral system should be developed. Disease management practices and appropriate community mobilization through genetic counseling for prevention should be placed in order. A concern for the welfare of affected children by means of offering free treatment should be implemented throughout India. Prevention and prevention of potential carriers who can transmit, that is the frontier of risk, what we say, the disease to future progeny should be made compulsory by means of prenatal and perinatal diagnosis and premarital detection for sickle cell gene at mass screening level.
Dr. Urade, thank you very much. And Dr. Pedrataya, you are listed here next to Dr. Urade. Dr. Rao Garu, I don't think Professor Graham or Serjeant is with us now.
Yes. Yeah.
Yeah,
Now,
we'll go ahead with the
You can
Dr.
go
Gadesh.
ahead with Dr. Pedrataya. He has just shared the link, his presentation. I am just downloading it. Meanwhile, Dr. Pedrataya, you can proceed with your
Yeah, thank you, sir. Thank you, Professor V.R. Rao, sir. The main purpose of the Anthropological Association for Humankind is to advocate the anthropological applications to solve human problems worldwide. So with this ambitious vision, we started this organization. So as part of it, to fulfill that vision, we have designed this World Applied Anthropology Congress to address the human issues, local and global issues. I'm very happy that Professor V.R. Rao sir has proposed a panel on global public health issue. It is sickle cell disease, particularly anthropological perspectives and relevance in addressing this issue. And what are the possible ways how this anthropological knowledge and applications can be utilized. That is the main motivation and intention of this proposing this panel. And when I see this, I was really excited. So this is exactly the purpose, as Professor Ravindranath Duggirala sir rightly mentioned, that this platform, World Applied Anthropology Congress, came into existence to address the issues that contemporary humans are facing. So yeah, in that, but actually I'm not the expert, or I don't have any experience in this field, particularly addressing the sickle cell disease. That honestly, I should confess before I do my presentation. So, I thank Professor V.R. Rao sir for giving me this opportunity to present the prevention and control of sickle cell disease and a global scenario. That is the topic of my presentation. So, about 120 million people are living with sickle cell disease globally. Sickle cell disease affects millions of people throughout the world and is particularly common among those whose ancestors came from sub-Saharan Africa, Spanish-speaking regions in the Western Hemisphere, South America, the Caribbean, the Central America, Saudi Arabia, India, and the Mediterranean countries such as Turkey, Greece, and Italy. The sickle cell, the HBS gene occurs at a variable frequency in Middle Eastern Arab countries with characteristic distribution patterns and representing an overall picture of blood genetic disorders in the region. In the Middle Eastern Arab countries, the clinical picture of sickle cell disease expresses two distinct forms, the benign and the severe forms, which are related to two distinct beta globin gene and haplotypes. Steps toward control and prevention. Both the sickle cell anemia and sickle cell disease pose health problems in most of the Middle Eastern Arab countries. Besides the need for care and rehabilitation for the affected patients, effective strategies for control and prevention were recognized as an essential measure toward decreasing the birth of affected children, primary prevention. For a successful control program, education, counseling, and increasing the awareness of chronicity of sickle cell anemia condition are essential approaches several countries have adopted effective steps toward condition prevention. For example, in the global scenario I have attempted, so I will bring a few ideas, information regarding this sickle cell disease in the African region and Nigeria, India, Cuba, USA, etc. Sickle cell disease in the African region, more than 66% of 120 million people affected worldwide by sickle cell disease live in Africa. Approximately 1,000 children are born with the disease every day in Africa, making it the most prevalent genetically acquired disease in the region. More than half of these children will die before they reach the age of 5, usually from infection or severe anemia. In the African region, 38,403 deaths from sickle cell disease were recorded in 2019, a 26% increase from 2000. Sickle cell disease in Nigeria, the situation. Nigeria is the epicenter zone with about 4 to 6 million people living with the disease. 1 in every 4 Nigerians has a sickle cell trait annually. About 3 lakh newly diagnosed sickle cell disease children are born worldwide. Sub-Saharan Africa contributes about 75% of the number. Nigeria accounts for 1 lakh to 1.5 lakh newborns living with the sickle cell disease annually, 33% of the global burden of sickle cell disease. Therefore, Nigeria occupies a strategic position in the epidemiology of sickle cell disease from the global perspective. Sickle cell disease in Nigeria, although Nigeria has the highest burden of the sickle cell disease worldwide, there is a still variable and a poor utilization of the standard of care practices for sickle cell disease patients in the country. Nigeria has, yeah, this is already covered. So a very high infant mortality due to infections occurs, especially in rural areas. Gallstones, leg ulcerations, and stroke appear less common than in American sicklers. And a plastic crisis have not been described. Poor availability of resources to the public health and the welfare sectors and economic inflation are severely curtailing access to the appropriate medical and social services. This situation is frustrating to the families of a growing number of surviving patients in the urban or middle to the upper income groups.
Dr. We'll have to pay attention to time.
Yes, sir. Yes, sir. So sickle cell disease situation in Cuba. Sickle cell anemia is the most common hereditary disease in Cuba. On average, 1 in 33 Cubans is a carrier of this severe hemolytic anemia that can cause early death. Early in 1980s, its incidence in Cuba was calculated at 1 in 1,600 births. In 1982, the Cuban public health system established the sickle cell anemia prevention program. In 1982 to 2018, the hemoglobin genotypes were tested. The 48,47,200 pregnant women. So under this program. Sickle cell disease in India, nationwide screening was conducted by Ministry of Tribal Affairs and ICMR during 2016 to 18. In this attempt, 13,83,664 persons were screened, after which 9,96,368 were tested positive, out of which 9,49,057 persons were trade carriers, and 47,311 persons are affected by disease. So under National Health Mission, Government of India supports the states for prevention and management of sickle cell disease as per the PAP proposals. So in the union budget of financial year 2023 to 24, it is announced to launch a mission to eliminate sickle cell anemia by 2047. The mission entails focus on awareness creation, a universal screening of approximately 7 crore people in the 0 to 40 years age group in affected tribal areas, and counseling through collaborative efforts of central ministries and state governments. The support corner envisioned as a one-stop portal with information around sickle cell disease in tribal regions of India. The portal will give access to real-time data to every visitor through a dashboard online self-registration facility is created through this program. So sickle cell disease in the US, approximately 2,000 infants with sickle cell disease are identified annually by US neonatal screening programs. Screening also identifies infants with other hemoglobinopathies and globinopathy carriers, and in some states, infants with alpha thalassemia syndromes. So sickle cell disease affects approximately 1 lakh Americans. So about 1 in 13 Black or African American babies is born with sickle cell disease trait. So yeah. Screening for sickle cell anemia. Newborns in the United States are by law screened for sickle cell anemia by at birth. The test uses the same blood samples used for other newborn tests. Early diagnosis is important because complications from the disease can arise early in life. Using genetic testing, doctors can now diagnose sickle cell disease even before birth, as early as 10 weeks into pregnancy. Yeah, disease and thalassemia major for the United Kingdom. The questions are left for 2 evidence-based reports. The 2 reports provide similar estimates for the for the burden of disease. One estimated that each year 28 to 60 fetuses are conceived, and 17 infants are born with thalassemia, and that 133 to 238 fetuses are conceived, and 168 infants are born with sickle cell disease in England. The other report gave the estimates for the United Kingdom of 44 and 171 respectively for conceptions. Both reports show that the population at risk has an uneven geographical distribution. Sickle cell disease law. The sickle cell disease runs a chronic course characterized by recurrent ill health, progressive organ damage, and shortened lifespan. There is a need for sickle cell control through public education and other preventive measures to shore up the political will and engagement, as well as financial resources for sickle cell disease prevention and control across the region. Particularly in our nation, India, this law, sickle cell disease prevention and control law is a must because of the situation. to raise public awareness of the disease in schools, communities, and health institutions, and the media, and advocate stronger health systems to ensure quality and uninterrupted services and equitable access to medicines and innovative tools. To create a specialized sickle cell care team comprising expert researchers and medical specialists, and continually focus on ways to prevent, diagnose, treat, and cure blood diseases should pave the way consistently in leading edge therapies and discoveries, leading to even more highly targeted care treatment. To facilitate a GO, INGO, and NGO collaboration in this prevention and control program is suggested, and to launch the processes of social mobilization and capacity development of the stakeholders in sickle cell disease is also important. What are the issues to tackle? The burden of sickle cell stems from low investment in the efforts to combat the disease. This is very dangerous, low investment. Many public health facilities across the region lack services for prevention, early detection, and care for sickle cell disease. Inadequate personnel and lack of services at lower level health facilities also hamper effective response to the disease.
Dr. Gade, I think we are running out of time, and please, if we can conclude, that will be great.
Yeah, maybe 1 or 2 minutes, sir. Sorry, sir. The World Health Organization guidelines published in 1998 stated that no compulsory genetic testing should be carried out. Nevertheless, some countries, including Iran, Saudi Arabia, Palestinian territories, and Cyprus, have laws in place making premarital screening for hemoglobinopathies mandatory for all couples before they are given approval to get married. 20 to 26, this raises ethical questions as the couples are unable to voluntarily decide for themselves whether they would like to undergo genetic screening. Management of sickle cell anemia regarding this, and we have experts here, so they know all these things. So I close my presentation here. Thank you, sir.
Thank you, Dr. Gade and Dr. V.R. Rao garu. It's now time for panel discussion. I would like to request you to lead the panel discussion, sir. Thank you. You are on mute, sir. Dr. Rao garu, you are on mute.
Yeah, Dr.
Yes.
Italia and Dr. Jene, Dipti Jene, they shared slides now. Whether we should take those slides, and then go for discussion?
Yeah. Yes, please.
Yeah. Then Dr. Italia, can you go ahead with your presentation? Dr. Italia, you can share your slides.
Yes, I'm coming.
Yeah, please.
You can see the slides?
Yes, yes.
Yeah.
Yeah.
Yep,
Yeah.
we can say.
Fine. Okay, so good evening, everybody. Thank you very much, Dr. Rao and Dr. Ravindranath, for inviting me over here in the panel discussion. I am from Gujarat, Valsad. This is a birthplace of sickle cell anemia control program in Gujarat as well as in India, if you can say. We started our activities by bringing science to the doorstep of tribal community. Valsad Raktadan Kendra and Government of Gujarat has an NGO project on sickle cell anemia control program, which was started in 2006. So our aim was that we are transferring, we have transformed small projects into a programmatic mode in Gujarat state. We started our journey in 1978 with the first patient diagnosed at Gujarat. And when I found that first patient in Gujarat, how can he be the first? There may be some others. And on screening, we found large number of tribal people who are suffering from sickle cell disease. And hence we started one NGO known as Avalsa Raktadan Kendra. And we started working through this NGO, but we found that one NGO is not good enough. One Italia is not good enough. And all patients, all people are poor and they are never going to any laboratory by spending their own money for carrying out the sickling test, and hence will remain undiagnosed throughout their life. So government should take some charge and do something. So I was always advocating the government people, the politicians, and finally in 2006, I was able to create political will in Gujarat state to start sickle cell program and integrate it with the ongoing government programs of the state authority. So in 2006, we started this program, and we have done a lot of work on sickle cell. Particularly, we carried out one on 13th of July 2006. It was inaugurated, and Gujarat is the first state in India to incorporate sickle cell anemia control program in the state government medical services. So the most important task we did in 2007 was to start screening of large number of tribal population of Gujarat. It was a huge task. We have 1 crore 40 lakhs tribal population in Gujarat. Out of that, so far we have screened 96.81 lakh tribal population, and we have found 7,22,000 sickle trait and 29,555, nearly 30,000 sickle cell disease patients. So all these sickle cell disease patients who were diagnosed under this program, we call it as a mass sickle cell screening program. All sickle disease patients were getting wrong treatment. They were misdiagnosed and mistreated. So after this screening program, all are getting proper treatment from the government, absolutely free of charge. We have multi-purpose health workers in the villages under the government program. We have ASA workers in the government program. So we approach this group of people through these ASA workers and multi-purpose health workers, and we provide them medicine at the doorstep of their home. So they are taking medicines. We collect empty foils whether they have taken the medicine in the last month or not. So before handing over new medicines, we take empty foils from them, confirming that they are taking medicines. Even hydroxyurea is also given to them. We encourage hydroxyurea in early stage so that organ damage can be prevented among this group of people. So if you consider this mass program of Gujarat, then about 89.70 lakh tribal population of India is having sickle gene. They are the carriers, and about 3.58 lakhs people are suffering from disease. And if you consider 17.64% decadal growth for 10 years, then every year about 6,324 new children are born with sickle cell disease. So initially in 2006, we have given them sickle cell positive people some cards with yellow color. Yellow color was chosen just because they have frequent jaundice, and it is well accepted in the tribal area of Gujarat. So normal white card was for normal hemoglobin, half yellow and half white for sickle trait, and completely yellow for sickle disease. So these laminated color-coded cards were given to all screened persons, And these color-coded cards are further used for marriage counseling that 2 yellow card people should avoid marriage. Now, the government of India is coming out with a Parichay portal. It's a portal where all sickle cell disease patients and everyone will be reported. The government wants to screen about 7 crore tribal population within few years. So this new ABHA card, ABHA ID cards will be issued from this Parichay portal of Government of India. This is the model one of card. It will be like this. We have also screened newborns under one Indo-US collaborative project. Totally 8,517 newborns were screened under this project, and we found 104 sickle cell disease and 1,341 sickle trait. We have given telephones, mobile phones to this children's parent, and we have kept follow-up for nearly 5 years of this group of people. So we have done some study with the Anthropology department of the Delhi University also, and one study was done in Gujarat and Jharkhand. There are about 201 people were tested, and we found that they have nutritional anemia with a lot of other problems. And health, India is a country where the issue of gender discrimination and disparity is widespread and often left unattended. So we found more anemia patients among the female rather than males. So health professionals, clinicians, NGOs, and government health policymakers should target nutritional interventions, prevent and treat undernourished people, and do something. The food micronutrients program, which is adopted by the government of India, is a right step to deal such problems. The other unhygienic conditions and parasitic infections like worms and malaria, etc., also plays major role for anemia in tribal areas. Nowadays, we don't find worms in stools, practically nil. If you want to teach somebody about the worms, you don't find ova or parasites in stools for the new doctors. So this is a one good sign for all of us. Now, it's a time for universal and dental screening of all ANC cases. And we have come out with project, particularly in Valsad district, that we are going to screen 100% ANC cases in government and in non-government organizations, hospitals, in rural area as well as in urban area. And this is an initiative by WAAC. It's a company which manufactures a number of things under the CSR activity in collaboration with District Health Authority. And we also want to screen newborns to find out whether our program is successful or not. In Gujarat, prenatal diagnosis for thalassemia and sickle cell anemia is free. In fact, under the scheme of Janani Sishu Suraksha Karyakram, this is the government of India's program. So under this program, in any state of India, all necessary investigations and treatment for the better health of mother and child is absolutely free. Cost of investigations for hemoglobinopathy and prenatal diagnosis can be booked under this scheme. So it is freely available in India. One should take advantage, the doctor should take advantage of it and do something for the people. At the moment, our approach is to cover government and non-government hospitals in Valsad city, Valsad district. So when a woman is pregnant and visits a doctor, whatever advice is given by doctor for her child or herself, she will definitely follow it. Even her mother-in-law will also insist for testing if she is there at the time of counseling. So all people are not aware of these genetic diseases, and counseling by a doctor with few kind words regarding the HPLC test for hemoglobinopathy will play a major role in reducing the burden of thalassemia major and sickle cell disease in society. Now, we know very well that inheritance is from both parents. We say that a sickle should not marry another sickle. We say that a thalassemic should not marry another thalassemic or another sickle. Then whom should they should marry a normal person who does not have any hemoglobinopathy. That means a sickle disease person should marry in a family with a normal hemoglobin. A thalassemic should also marry to a family which has normal hemoglobin. That means we are introducing an abnormal gene into a normal family. Are we adding abnormal gene into normal family? Every 25-30 years the generation changes. And when the generation changes, after about such 10, 15, 20 generations, each and every family will have either sickle or thalassemia or any other hemoglobin variants. So we have to think about long-term or short-term gain. We have a science today. Initially in 2006, we used the card that 2 yellow card people should avoid marriage. Now we have a science, we have a facility, our doctors are well trained and they can prevent birth of a sickle disease child by prenatal diagnosis. If there are 2 fetus, they can diagnose either of them as a sickle disease and trait or normal and will abort only the diseased one. So that much capacity has been developed by our doctors. We should take advantage. Even the patients with having multiple, even after 2-3 prenatal diagnosis, if the patient is going to give birth of a sickle disease child, then we can use assisted pregnancy also with IFA and other technology. So we should try our best, let people marry with anybody, perform HPLC test of each and every antenatal patient. If positive, screen their husbands, and if both are positive, go for prenatal diagnosis. Now the prenatal diagnosis, if you want to do prenatal diagnosis, you must have consent from the couple. It should be 100% voluntary, and there should be given absolute information regarding all these procedures and other things, and let people only decide. Sorry, let people only decide what they want to do. During 2021 to 22, 253,903 ANC cases in government hospitals in Gujarat were screened. Out of that, 150,581 were from the tribal area, and 2,545 were found to be trait, and 169 were of disease. Their husbands were also screened, and all high-risk couples were counseled for prenatal diagnosis, and those who were ready for MTP, those who are ready for MTP after prenatal diagnosis were only subjected to prenatal diagnosis before 20 weeks of pregnancy. So this is very common thing going on, at least in South Gujarat area where sickle is more, and people are well aware because we are working since 1984 for these people, and there is hardly any stigma about this type of disease. So it is time for 100% voluntary universal screening of all antenatal patients in India. Offer them free investigation facility. Don't wait for the legislative rules and regulations to come. Give them free facility, investigation facility. Let them decide. IEC is a must in local languages. Educate the people and let them take their own decision. I am sure that any person who has seen the suffering of either thalassemia or sickle cell disease will never wish to have such child in their own family. So this is the group of our people working. Dr. Serjeant was here. Dr. Kate is here. Padma Shri Dr. Kate. Our all staff. Ram Teke is also here. So all have visited. Whoever is not visited so far, please do come. Gujarat mein aapka swagat hai. Do come to Gujarat. Thank you very much for paying attention to our sicklers. Thank you.
Thank you.
Thank you, Dr. Italia. Thank you, Dr. Italia.
Thank you.
Now, friends, I'll be going ahead with my presentation. As I was informing you, I was asked by the World Forum to have this panel discussion. I have three basic anthropological issues which I would like to discuss as a panel, here. My slides are being shared or no? I have to see that. Dr. Duggirala garu, thank you.
Thank you very much.
Yeah, I'm just trying to share the slides. Because yes. Is it visible slide? Hello?
Yeah.
Yeah. Oh, thank you. Yeah. I have three basic issues. What I would like to deal here is that human evolutionary context, and I want to bring it here because I have some issue there, and hotspot regions for sickle cell, and implementation, impact, evaluation. These are the three issues I would like to discuss. Issue one is G6PD inclusion in hemoglobinopathies, thalassemia, sickle cell disease, and variant hemoglobin prevention and control programs. Why? Because in an evolutionary context, you can always see the disease processes are related to different lives in terms of sustenance. Hunter-gatherers, infectious diseases, pastoralists, we have different disease processes. Hemoglobinopathies and deficiency, we see as a response to agriculture practices and malaria, Valsparum endemicity. Okay, this is all evolutionary context. Now, sickle cell, beta thalassemia, HBE, HBD, G6PD are complementary in prevalence. For example, I'll show you in the Indian populations, you do have about 8% of tribes and all other general populations. Among tribes, you see Dravidian tribes, sickle cell. Dravidian tribe is the founder populations here, and Austroasiatic tribes. You see, among our Dravidian tribes, we also have Austroasiatic tribes. They have G6PD deficiency, and Tibeto-Burman has got HBE deficiency. This type of stratification you find in terms of prevalence and caste populations. All these traits, HBS, we know it is tribal origin, but it has percolated caste populations. Like that HBE, we know that is Tibeto-Burman, and HBD is Punjab. Okay, HBD is on Punjab. We can always think of Punjab, this particular trait in Punjab. G6PD deficiency, percolation from source population Austroasiatic. Beta thalassemia, we have source populations which are we can always identify who are those source populations. G6PD is known to cause drug-induced anemia, jaundice, and child mortality and morbidity. Also, recent studies show serious mental illness like autism. you look at the frequencies, prevalence rates, different tribal and caste populations, this frequency is, very high among Assamese, Assam populations, and Meghalaya. And here also we have Maharashtra, Parsis, they have high frequency, some caste groups, some religious groups. So G6PD deficiency is prevalent in Indian populations. Then our discussion now, let us go by interactive type of thing, for this particular recommendation to include G6PD in screening programs along with hemoglobinopathies. If this is open for discussion. Yes, panelists, you can react. You can have your opinion on this.
Yes, can I?
Yes, please.
I am Dr. Jyotish Patel.
Yes.
I have been practicing in tribal regions since last 35 years. The issue of G6PD is between somewhere around 2 to 3%, or at times, it may be up to 5% in certain communities.
Yeah.
But the issue of sickle cell anemia is huge.
Yeah.
Sickle cell disease is a morbid condition having very high mortality. G6PD deficiency, we know for sure that it can be a quantitative deficiency or it can be a qualitative deficiency. And whatever we have seen and studied here, that G6PD deficiency variant that we have in our region, as well as that is not that much dangerous. Even we have used primaquine without screening population for G6PD deficiency as a radical cure for malaria management. So I don't think that G6PD should be a part of the present project as far as India is concerned. I am very clear that that issue of sickle cell anemia is huge and it needs to be in the focus.
Okay.
If we try to incorporate some of the other things along with this, then we are possibly not doing justice to the leftover issue of sickle cell anemia so many years.
Okay, thank you. Thank you. Thanks for Jyotish, thank you very much. Dr. Saraswati, madam.
Yeah.
Sir, your presentation was excellent, and I fully agree that G6PD deficiency can be added in the national program, because very recently we have done a small MSc dissertation study in some Udaipur district. And sir, and I also want to say that G6PD is common among the non-tribal communities of India, whereas sickle cell is common, as you said, it is among the tribal communities, and that too among the Dravidian speakers and South Indian central tribal groups. So G6PD should be, I think it is slightly bigger problem which is ignored. And then moreover, this is the first pharmacogenetic disease, and the drug reactions, and it is males who will be affected if the drug is given. Sulfa drugs are given to those people who are G6PD deficient. There is very, very, very bad adverse conditions. So I think G6PD should be included in the national program as far as my knowledge goes. And that study I'm talking about in Udaipur, when we collected the data on some non-tribal communities, around 200 individuals, we got 3 deficient people, and all the 3 deficient people are from a younger age. So I wrote, it was published in a very small journal. I wrote that maybe G6PD deficient males are not able to survive to higher ages because of the all the hemoglobinopathies carriers. Of course, it is hemizygous condition. They all have severe anemic conditions, and which make them prone to various diseases and infections. So this is an important aspect. I think we should be considering it to be a part of national program. Thank you, sir.
Professor Rao, I'd like to add, I like to agree with the Professor Jyotish Patel that sickle cell and hemoglobin thalassemia disorders are totally different from G6PD, and we should not dilute these hemoglobinopathies with G6PD. And see, both of these are common in diagnosis, in treatment, in management, in complications. Even let it be bone marrow transplantation, gene therapy, all are similar. But G6 is altogether different condition. I think we should not dilute the hemoglobinopathies with the G6PD.
Yes, noted, Dr. Arora.
I would
Any other?
then, yes. Can I speak?
Yeah,
Dr. Rao?
Dr. Jene, please,
Yes.
please.
Yeah. My experience is I think at this moment, we are not yet prepared to have a national program for G6PD deficiency. However, one observation we have in our population in Vidarbha, that homozygous sickle cell disease have higher prevalence of G6PD deficiency than normal population. So I would suggest, because sickle cell patients have hemolytic crisis, they have jaundice, maybe once they are diagnosed with homozygous, they should be screened for G6PD deficiency.
Correct.
Understood, madam.
Thank
Thank you. Doctor, thank you, madam. Any other observation?
Dr. Rao garu, with
Ah.
my little knowledge, in this area, I have two questions,
Yeah.
One is, is there any coincidence of both diseases, in these communities? That is the first question. And the second question is, prevention and control programs are fantastic, but the thing is, how about disease management? What
That
people
will
have
come.
been doing?
That will come, Dr. Professor. That will come.
Okay.
That issue of management, that we will be in due course. We'll come to that. Okay. Now the issue is GSP deficiency.
Sir, can I react, sir, if you don't mind?
Yeah, please.
Sir, I agree that once sickle cell disease patients are identified, they're already in crisis. Whether G6PD deficient or not deficient, it shouldn't really matter. The course of treatment is different, number one. Number two, when we talk of sickle cell carriers, and I think definitely sickle cell anemia is different, as Dr. Arora said and Dr. Madam also said. These are not on hemoglobin gene. G6PD is on a different, it is an X-linked disease. It has a different aspect. But sir, G6PD deficiency is important in the Indian context because anti-malarial drugs are being given to people as a part of preventive strategies many a times. So in such cases, G6PD deficient individuals will be at higher risk. So even if it is not a part of abnormal hemoglobin in terms of hemoglobin, but it is a hemoglobinopathy. If the government of India is working on hemoglobinopathies, this may not be on the hemoglobin gene, but it is one of the hemoglobin. It is affecting the hemoglobin content. So I think it should be affected. Thank you.
Okay. Yes, any other observation, Dr. Roche? Yes.
Yeah, sir.
Yes, please. Dr. Orade.
Sir, G6PD, since we are dealing with the genetic aspects of the hemoglobinopathies, and there is an association between these hemoglobinopathies and G6PD. G6PD is very, very important from public health point of view. So we must include the G6PD in the hemoglobinopathies.
Yes, sir. Dr. Orade, thank you. Dr. Roshan Kolar, she has been, one of the driving forces in drafting the guidelines, and even the draft policies. And there, they clearly said what Dr. Arora was and other Jyotish Patel was sharing with us, that the beta thalassemia, sickle cell anemia belong to globin gene, deficiencies. G6PD does not fit in there. That is what they have written. But as an evolutionary point of view, this also has evolved in the populations. We are unable to, because I see, I am now a practicing geneticist in Genome Foundation. Autism children, I see G6PD deficiency causes autism. That we have, in fact, a lot of evidences in terms of stem cells, which research is being done. G6PD molecule, if you see, is the only molecule, major molecule, which in terms of oxygen, oxygen supply to whole body, and only the deficiency, and this particular molecule also stabilizes reaction oxygen species. Now, what we found in autism cases is that these deficient people, they have inflammation, okay? Amygdala, some cells, neural cells are affected. So, in fact, when we talk about this sickle cell, and in Northeast, sickle cell is not a problem. Hemoglobin E is the problem, but it is not of severe clinical consequences. Only problem is G6PD deficiency. We have a lot of population studies going up to 24% in Nagas. Austroasiatic tribes, we have not seen sickle cell is in Dravidian tribes. Austroasiatics, we have Chenchus. Chenchus Anadis in Andhra, they think they are tribals and they are Dravidian tribes, but sickle cell is very low, but this is very high. So the issue is in terms of screening, G6PD require. In fact, as a tradition where Dr. Kola worked for long years, Institute of Immunohematology, where I was also there along with the team. I did my PhD there. We were all doing population surveys, including all these hemoglobinopathies and G6PD deficiency. We used to take the test papers and do that, okay? So this has been done in population screening. This is a Bombay tradition, Dr. Undevia, Dr. Bhatia, Dr. Sukumar, whoever is doing on hemoglobinopathies, they used to insist this is deficiency. Afterwards, I drifted into different areas, Anyway, when I am now into genetics, I see the problem of this deficiency. And in Northeast, there are this state government run mental hospitals. We don't know, we have no idea. I worked in Idumishmis, and when we found that depression is very high frequency, suicides are very high, we were looking into so many other genetic factors, we missed this deficiency. We don't know what is happening in the populations. Yes, clinicians are right. Clinicians are right that they need critical evidence, That evidence comes only after epidemiology is done. Once we go to population epidemiology, identify deficient cases. Yes, quantitative, qualitative method. Qualitative.
Dr. Rao?
Yes. Yes, please. Yes. Any observation?
I like to share my experience. In my last 40 years clinical experience, I have just one G6PD case.
Dr. Rao?
Yeah.
And after more than 5,000
Can I-
not
Can I say?
Dr. Mukherjee, you were in Chandrapur. Tell us.
No, see, there are two issues what you are talking. One is the population survey, another is the national screening program.
Okay.
You also agreed with me that G6PD deficiency, whatever we do in the population, they are all asymptomatic. G6PD, as per WHO criteria, if you see, whatever the cases we get, mostly it is a class 3 or class 4 variant. It is not the class 1 severe, which is the drug-induced hemolytic anemia. It is a problem with the neonatal jaundice. If G6PD, then they are very severe. And that's why some of the state, in newborn screening program, G6PD deficiency screening is compulsory. So I think we have to think in two ways. One is the population survey, that is a different issue. And there is another thing is that if you want to include in the national program, then as the others, Dr. Jyotish Patel and others, they said that, or Dr. Arora, that it may get dilute the screening program of hemoglobinopathies, because hemoglobinopathies is much more problem than the G6PD. And we don't have much clinical data about the G6PD deficiency.
Yes.
I also agree, if I can add.
Roshan Kola, Dr. Roshan Kola, please.
Yeah. So I also agree with Dr. Dipti Jain that for a national program, it's difficult to screen everybody for G6PD. And whom are you going to screen? Only the males? Or you're just going to screen this huge population that you're screening for sickle cell? It's not going to be feasible. So as Dr. Dipti said, once you identify sickle homozygotes, at least for them, maybe initially the screening can be done. But Malay also said there are two aspects. One is an anthropological aspect, and the other one is control of hemoglobinopathies or sickle cell disease over here that we are talking.
Yes,
Can I,
understand.
Dr. Rao garu,
Yeah,
can I
Chapan.
ask you one question again? This is not
Yeah.
my field, you know.
Yeah.
I already asked this question, you know, are there any
Go ahead.
data, solid data about comorbidity, you know, co-occurrence of both sickle cell anemia and G6PD deficiency? It
Yes,
looks like there are a few
yeah.
studies done on that. When people have, you know, both problems, you know,
Yes.
oxidative stress, you know, is a big issue. So are there any data that are showing, you know, comorbidity information? And when they have comorbidity, what is the severity of the problem, health issues? Could you
Yes,
please comment on that?
Yeah, I'll tell you.
Professor, in population surveys, I myself, we found comorbidity, sickle cell and G6PD deficiency. And Dr. Jene, in our clinical practice, very rarely one case, you know. This is what the situation. Yes.
No, I will say
Yeah.
patients of sickle cell disease who have hemolytic crisis, they are the ones who have comorbidity of G6PD deficiency.
Yes.
And let me tell you that hyperhemolysis crisis, which is written in the Western textbook, right? We have hardly seen in India. In fact, if there is a hyperhemolysis, I think the reason could be, you know, the bad malaria that patient has, because of which there is hyperhemolysis. At times, it is the infection which is causing an issue, and not the G6PD deficiency.
Dr. Jyotish, we do find G6PD.
Yeah,
you said malaria, fine.
I do not deny
we are talking of Gujarat, but in Maharashtra, now Vidarbha area, we do get G6PD deficiency.
I do not deny it, but at the same time, the hyperhemolytic crisis, which is mentioned so frequently, right? It is not so frequent as we get patients.
Yeah, it is not only G6PD deficiency. There are other factors also.
That is what I'm saying. That is what I'm
saying.
Friends,
I may have to stop the discussion here. And whatever, you know, further, you know, we can always discuss.
Sure.
But what Dr. Malay Mukherjee was telling is like this, that newborn screening, even in sickle cell, you know, we have those programs, you know. If it's a national newborn screening program, G6PD is included, that serves the purpose. Okay. So in terms of, you know, one thing is what to my mind, including G6PD deficiency in the screening program, population screening, it derails other sickle program that, you know, I'm a little bit hard to be convinced. And then we leave the discussion here and we proceed further.
Yeah.
Issue 2 is prioritization, hotspot regions. When we know that sickle cell prevention, the population is highly stratified Indian population structure and sickle cell prevalence and spread. You see, we have, you know, in South, Irula, Kurumba, Paniyan cluster, 40% up to 40%. Yanadi, Erupula, Chensus, they have G6PD deficiencies, but sickle cell is sporadic. Goans have high sickle cell, Bills have got high sickle cell, Kolarian, Dorian, Konkan, these are Austroasiatic tribes that the sickle cell is about 18%. Santal Mundaris, okay, these are tribal populations in Bihar and Orissa, where sickle cell is very high in Chhattisgarh, Orissa, but Santal Mundaris, you cannot find sickle cell there. You find sporadic sickle cell, but G6PD deficiency. This is the Austroasiatic group. Sub-Himalayan groups and all that, the sickle cell is absent. Now, this is a distribution of, you know, sickle cell in various populations. You always find, you know, Paniyans having high risk. And here, Pradhans are having more than 30%. Like that in the populations, you know, we do have some populations, Patelias, Patelia, this type of, you know, populations. But we don't know what is now happening in this. Whether they're increasing or decreasing, we have no idea. We don't have temporal data for this. And now the sickle cell is found in all the population. It is percolating to different caste configurations. We do have tribals. We do have in lower caste, middle caste, higher caste. Okay, there is a particular dynamism happening, you know, in the population level. The malarial endemicity. In terms of attack falciparum index, when we looked into Kerala, the incidence of malaria is low. As we proceed further, we have high incidences. Accordingly, the spread of HBS is very well correlated. Is correlated with attack falciparum index. There are several maps attempted, like heat maps based on expected allele frequencies, projections. There are several projections, But what we did here is that we have cultural zones, You all know each state formation is a linguistic categorization, is a cultural trait, language. Within linguistic regions, there are cultural zones. In Maharashtra, Vidarbha region, Konkan region, Desastha region, and Marathwada region. There the caste confederations, tribals, all are distinct, in terms of intermarriages between one particular culture zone to another particular culture zone, it is very, very rare. And in that perspective, what we did, we looked at sickle cell prevalence and also the cultural zones. We do have clear-cut distinction in the south when we say focus one, Telanadu and Malabar, Panian in Indira complex, that is here about 9 districts. We can say they are the core districts, and there is a little bit extension, there are one or two districts extension. Bastar, Plateau, Dandakaranya, there are cultural zones. Okay, it covers about 91 districts, Total Chhattisgarh and Orissa, we have major initiative programs there. And even its extension in terms of, widely extended because of malaria endemicity must be. And also in Malwa, Nimar, Bundelkhand region, culture zones, these are the districts which we have 29 districts here, and it also extended. So this is a map of anthropological map, and from that point of view, we say there are high risk zones. Okay. Now the question is, sickle cell gene will continue to exist and spread in human populations as long as Plasmodium falciparum exists. Even if PF is eliminated, sickle cell gene frequencies are bound to be maintained by population factor themselves. In fact, we do see such type of stabilization of the gene frequencies for sickle cell in populations like actual tribal populations, okay? Only it has percolated slower fast populations and some mixed tribal populations, they have high frequencies. Our efforts and program should be to prevent sickle cell disease and provide state-of-the-art clinical management of children born with sickle cell disease. Now discussion, whether we should prioritize prevention and control programs. Whether, friends, please react to this, whether we need to prioritize our prevention control programs in hotspot regions. In fact, all the programs that are being conducted is in hotspot regions, both NGO programs especially. But the government of India has got universal vertical India, all India, okay. There are issues like in Northeast, there's no sickle cell. Then what type of facilities are going to create there at a district level? Already in terms of implementation, we do see this red cell units all over the country, and they are going to screen populations, create hospitals, multi-specialty clinics, and sickle cell disease challenges are different from beta thalassemia disease challenges. So how we are going to, in terms of take care of all this, in terms of the budgetary allocation, and maybe for sickle cell. When I say sickle cell prioritization, it is not that only sickle cell is being screened. All the policy, we should screen even beta thalassemia also, and sickle cell, all the screening programs, whatever are recommended in the guidelines.
Can
So-
I comment on this, sir?
Madam, please.
Yes. Sir, that is a very good concept of hotspot regions, but the universal screening will be the best. And basically what Yazdi Atalia sir has said about the antenatal screening for prevention of hemoglobinopathies. You know, there is and it should not only be the sickle cell, as you have said. With the sickle cell, other hemoglobinopathies should also be included. If we are doing just a solubility test, then definitely it will be the sickle cell and all. But along with sickle cell, we can go for an Nestroff test and then or CBP. And then if it is positive or something MCV is low or other things, then we can go for HPLCs and other things. That is my thing.
Yes, madam. Thank you.
I like to add, Professor Rao, that as far as prevention and control is concerned, we should do universal, as told by Dr. Sumanjan as well. Because see, by looking at CBC and HPLC, we can diagnose both simultaneously, sickle cell and thalassemia as well. However, for the treatment part, yes, we can look for the hotspots because sickle is not very common in North India. So we can, for the treatment part, we can look more on the tribal areas, and for thalassemia, we can more on where the thalassemia goes. For treatment, we can have different strategy, but for prevention control, it should be universal.
Yes, Dr. Arora, I understood.
I'll just
in terms of, universal screening program. Okay, suppose once we have universal screening program in the hotspot regions, we can go for universal screening program. Okay, that is what the recommendation for all of us. We should impress upon the government. We need to consider all pregnant women screened. Okay, this is one agenda which it is going to come next. Now, any other observations, please?
As far as Dr. Rao, you have brought out with a very important point.
Yeah.
One thing is that it is not only a disease of the tribal population, it is widely spread even in the non-tribal population across India. That is
very true.
Number two, about the policy of universal program to screen all population up to 40 years of age. I think India has a huge mass. If government can do it, it is fine. But we can have a little focused attitude wherein what we have done over a period of time, those patients who are coming to a clinic, hospital, and taken a sample for any examination should be tested for hemoglobin S and thalassemia. That will help us to detect so many young babies, even the adult population.
Right.
Going further, those who are diagnosed with sickle cell disease, there is an urgent need to give a best kind of treatment. There is so much of a disparity in the management, and people that think that giving folic acid is something heroic thing that they are doing for the sickle cell management, which is beyond consideration. Apart from folic acid, there are so many things which are there. And going further, I have a research paper in my hand which says that there is a transition of the pediatric population to adult population, which is a great problem, even a country like US. They have done a much out of this. And there are issues of pediatric management, which are when they are transition and go to adult population, they are mismanaged. And let me tell you that pediatric mortality is there in some of the parts. We do not have pediatric mortality nowadays. But adults are at very high risk of acute chest syndrome. And there is a need to develop sophisticated, well-equipped healthcare facilities, which means a doctor who is knowledgeable with sickle cell management. Their RMOs are manageable with sickle cell management. Not only that, the nurses are should have a good information about sickle cell observation and their management. And at times, at platform, there are so many things which are told and which seems that we have done something heroic as far as sickle cell is concerned. This US paper is so transparent. They are even convinced today that even in US, we have an issue of healthcare management, provision of management to adult cases of sickle cell disease, and including Gujarat, nobody is good as far as sickle cell management is concerned.
Yes, doctor.
It is always good to talk.
Yeah.
As far as you know, we have done this, that is fine. Modalities are totally different.
Yeah, right. With a
Yeah.
multi-specialty.
That's a very good point.
Yeah,
Yeah.
multi-specialty clinical effort, So friends,
Absolutely.
I will
Can I
proceed
say something?
further. Yes, who is that?
I'm Saraswati, sir.
Madam, please.
Sir, I just, sorry, I'm not able to recollect the name of the doctor who just spoke now. I fully agree with him, sir.
I am Dr. Jyotish Patel.
Jyotish Patel.
Thank you, sir. Thank you. I fully agree with you about these, whatever you said. Sir, yeah, regarding the folic acid supplementation or folic acid based treatment, recently I met one of two professors while screening thalassemia. Professor, they are heterozygotes for thalassemia, and then traits, sir, and they are basically given folic acid. And my research is based actually on against folic acid indiscriminate supplementation of folic acid. Folic acid has got very, very bad adverse effects. Especially, it is the increase of cancers in populations is attributed to over folic acid. Especially in Indian context, we are vegetarian community. Folic acid treatment should be really revisited and thought about. Thank you, sir.
Absolutely.
Yes, madam. The point is well taken,
Yeah.
So we'll proceed further. May I know who is there?
Another meeting actually. Sorry for that, but I have to go for the meeting, and I have heard the discussions. But I will like to say one thing only here. We have just started sickle cell mission, and the hemoglobinopathies took place in 2013-14.
Yes.
But the things are there, and we have heard many good things that the country needs a time. Okay, we all need time for it. And certainly it will be one of the topmost country of the world. I'm assuring that we will come up with such strategies from prevention to treatment. What we are talking about prevention, treatment, referral mechanism, everything will be in place. And we are committed to it. Government of India is committed. And now it is not only one department which is dealing with it. It's not only health. Every department has got a role to do something.
Sure.
Converge. It means a lot. It's not only the health department which is going earlier. What was happening now? This is the time when Honorable PM has taken up the issues, and he said now it is the time that everybody has to join hands and come up with the strategies which is going to take up in the coming year. Within 3 years or 4 years, we will come up with such mission that is going to reduce the burden, and the treatment part will be taken up very nicely and appropriately. So with these words, I will take
It's
your
8 o'clock.
move because I have to go for another meeting. So thank you so much. And it was a good, and is that I have been, I'm knowing all the people, the members over here, because they are very committed people. Whatever we have from either from Italia or Jyotish Patel or Roshan Kola madam, Deepthi madam, anywhere, they have worked very hard. And that's why this program is here. We should be thankful to everybody, rather every individual scientist, Malay Mukherjee I've heard, and every scientist and the doctors, the clinicians who have really worked hard to come up to this stage. And this is important. I say whatever we say, but this is important that now we have to realize the commitment of the government and we should work towards it. Thank you so much.
Thank you, madam, very much. Thank you. Friends, I will proceed the last issue. The last issue is like this. Now, the question of implementation of programs. We have listened to the programs that are being implemented at the field level. Okay, it's a big issue, but the question is, it's a harmonization. Several efforts are there. Okay, I am yet to listen from our colleague Nandakumar from South. We have listened to Dr. Patra, Dr. Italia from West, Dr. Patra from Central. It's a big issue. Implementation of programs is a big issue. Why it is big? Because whatever we do, is there a scientific evaluation, impact evaluation? See, I can always say, like, I have done this work. The people approached me for prenatal diagnosis. In terms of evaluation, impact evaluation, we need to have cultural, sensitization and how you evaluate that impact, that is very important. Need to be considered as this I want to consider it as an anthropological issue because majorly concerned with cultural impact. Outcome variables. Any program which we do, we should identify our outcome variables. One is institutional arrangements, infrastructure. Though this variable not anthropological or an outcome variable, but important. What we are looking, our outcome variable should be decrease in sickle cell gene frequencies in populations over time. Do you have any baseline data where you say that the sickle cell gene frequency has come down? Do you have any data to say that the births with sickle cell have reduced, okay, over time? This type of, the registry is being thought about, national registry, linking to our Aadhaar cards, but impact is always local. You cannot imagine in a vertical governance, the impact will be at the apex. It has to be bottom up. So the ground level, whoever is working, mostly NGOs, working. Now, Dr. Srivastava told the government is equally involving themselves with this vertical program. Now, what is important is evidence-based observation. High gene frequencies in the population leads to, in fact, when I talked about whether the gene frequencies are increasing or decreasing in populations, wherever gene frequency is high, okay, there the disease course is severe and more number of sickle cell disease births. This is what, in terms of some evidence on one or two studies, okay, but we need to have this a platform, in terms of registry, whatever you say, we need to be able to measure this impact. Now we know what is high or low frequencies in our population structure. Decrease in societal stigmatization. This is very important variable whenever you are implementing your programs. Decrease in sickle disease births over time. Impact evaluation. Institutional arrangement, let us look at it. Trained manpower is required. Instruments should be functional. Multi-specialty clinicians, which is entirely different challenge for sickle cell. All screening programs, carrier, pregnant woman, cascade, newborn, will be successful only if all this infrastructure is available immediately. It is not that you have undertaken massive screening program and you are developing an infrastructure. So the suggestion is, initially for 10 to 20 years, GO-NGO model. In only Gujarat, we are finding this Government of India NGO model. In fact, in the policy, it was written that local NGOs who are working, who can connect to the communities, they should be involved in these programs initially until the government's infrastructure, training on manpower, putting their instruments in operation happens. That type of exit policy. One can have an exit policy. After 20 years, NGOs are out of this model. It is carried out by the entirely the government mechanisms. Now, ultimately, sickle cell is a long-term commitment. Government universal vertical model is the only resource. We do agree for it. But what is important is, look at the situation here. Look at the impact of the budget spend. Look at the impact of programs. Where is the evidence to show that all of the programs are harmonized? There are different programs, different challenges. There are GO-NGO model one place. It is not there in other places. So that has to be mandated. The NGOs should be involved in local impact evaluations. Decrease in sickle cell gene frequencies in population over time. What we want from massive screening programs, only I need 100 unrelated samples from, suppose if a district, there are 50 population endogamous group, I need only 5,000 samples, will give representative gene frequencies for long-term monitoring, okay? If I want to know whether the population frequencies are decreasing or increasing, I need to have baseline data. Genetic code distribution has been discussed. Parts are distributed. What is the cultural impact? Where is the assessment of the use? We need empirical evidence, you know. In fact, in Canada, what they did was cultural, these genetic codes, what is the type of use, how they used, that has been documented. So we need to have a impact evaluation. One thing I want to ask you all is that in a massive screening program, when you are identifying cultural the carriers and homozygotes, why you need to give cards in public? Why can't you, if you already have an infrastructure, you need to go to the families, contact the families, make it a cascade screening program, bring them to hospitals, counsel them, and give them the cards. And even you can say all the anemic patient students or adults, you can call them to the hospital. Then you disclose, you have this sickle cell anemia. This is what you have to do. Instead of publicly giving to the cards. I know my field experience says that there are dramatically traumatic events in the situation. And decrease in societal segment is important. Not that in a mass screening program you are educating the students or whomever is screened. The IEC material, see, that is information, education, communication material. Content development is a big cultural job, cultural sensitivity. Periodical caps and recaps. This part of education is to across the society, not to the person whom we have screened. Show me any one of the documentation. We see figures and videos. No. Can you have an evaluation of knowledge, attitude, and practice of across the society, about nurses, about doctors, about school teachers? That is very important to reduce stigmatization. That has to be periodically evaluated. Decrease in sickle cell disease births over time. Periodical parents, I look for parents voluntarily agreeing fetus genetic screening. If there are any cultural blocks, we have to identify and remove them. Even cascade screening, when I do and I educate the people, family, I anticipate they have to voluntarily come for screening, testing of their relatives. This is what, cultural impact evaluation. You need to think in terms of, a change, cultural change, how to bring cultural change. Now the discussion point. We need to be very quick here, whether initiating programs in collaboration with a GO model with expertise, technical and technical capabilities, working in the area for the last decade or so with an exit policy in place can be mandated. Okay? Now it is not happening. It has to happen. Okay? This is one discussion point. Recommending independent periodical impact evaluation. I want this impact evaluation independently done by a third party. The constitutional bodies like Cultural Ministry, Government of India is a cultural ministry. They have Anthropological Survey of India. They can be given this task. You implement your programs. I am going to evaluate this. So these are the 2 points. Quickly, if any, any remarks, then we have to close the discussion, and we have our mothers of sickle cell WAAC.
Yes. We need to listen from Mrs. Jaya Sampath Ramteke and Mrs. Preeti Nagar. Dr. Meenan wants to talk, sir.
Any response for this quickly? Any response?
Dr. Meenan.
Just 30 seconds.
Yeah.
Talking about culture, I just wanted to give one of my experiences while I was doing in 1994 in genetic pediatric ward in AIM. I found a lady, pregnant woman. She was every day coming to the ward and she was sitting and pleading doctors. After 4 days, I asked her, what is the problem? She said, I am carrying a thalassemia major child fetus. And then what is the problem then? They are asking me to abort. Then that you have to go for abortion. She said, I want to know the sex of the child. Then she said, I said, why? Anyway, you have to go. And if it is a male child, I would like to be called a mother of the boy. Even if he dies within 1 year, doesn't matter. But a female child, I would like to go for abortion. So this is something very, very important. I just wanted people to know about it. Thank you.
This is a cultural block, madam. This
Yes,
cultural block has to be removed.
So this type of situations can be handled by the local NGOs or local people.
Yes, yes, yes.
And national,
Awareness,
unless
awareness
you
is important.
Yes.
One quotation which I wrote on my book in Gujarati and Hindi, it was mentioned, sickle cell का मरीज अच्छा जीवन जी सकता है. You know, it was a positive quotation which was written by me on the book, which changed the scenario. So at times there is a need of repurposing of the, the knowledge and attitude of the doctors also. The doctors, they are saying at the moment that there is no treatment for the sickle cell disease. It is only folic acid which is available. So there is a need to do something.
Dr. Jyotish, kindly respond to these two questions. We have to close the discussion.
Sure. And
Yes,
as far as cultural practice is concerned, now in our region, at least I can tell you that there are so many expected couples who come for their testing. They are well aware of it.
Dr. Jyotish, you are not, see, the question is scientific evaluation, third party evaluation.
That should be there. That should be there. Yeah, I agree with you.
Thank you. Any other, suppose if no other.
Yes,
Dr. Menon is there.
Yeah, Dr. Menon wants to say something, sir.
I just want to mention that in Tamil Nadu, we have a cooperation with the government.
I was waiting for you.
Yeah, the government of Tamil Nadu actually is supporting our program, sickle cell program here. As far as the genetic, whether AS is increasing in our tribal population, it is increasing because there is more consanguineous marriage taking place. Previously, the tribal population used to travel all over Kerala. Now that it is divided into 2 states, the people over here speak Tamil. So there is more of consanguinity. The other population, the non-tribal population here, it is decreasing because they have realized that they have a high incidence of sickle cell disease and they are voluntarily marrying into the plains of Tamil Nadu, where sickle cell disease is quite rare. So they have sorted out the problem by themselves. They have taken the stand of having their children have alliances in the plains. So the incidence of sickle cell disease as well as the trait is decreasing in that group.
Okay. Any data?
Yes, we have data for the tribal population. The Chetty population is reluctant to test now because they're saying that the people who have sickle cell disease will be obvious. They'll come to the hospital anyway. The ones with trait we don't want to find out is their stand.
Okay.
So I also hear from Ms. Nagrare and Ms. Ramteke, please.
Yes, Professor, before that, let me share, my experiences or my encounters or my association with late Dr. Sampath Ramteke. Okay, he was awarded, as you said, Padma Shri for his work, as a single man mission, to educate his own people. Went to villages, okay, on his own. Whenever we sit, in one of the gardens in Nagpur, when I was there, and we used to discuss, he used to ask us, what is the scientific, how to communicate, what are the, in terms of sickle cell disease, you want to know, inheritance, you want to know, genetics, you want to know, what is the happening in other parts of India, he want to know. So we used to discuss, and he used to observe and make notes and take to different interior areas, he has in fact played a very monumental role, for each government of India has recognized his services. I am glad Ms. Jaya Ramteke, she is continuing his services. Okay, she said when I told, Madam, this type of conference we're going to have, can you join? Yes, sir, I would like to join. I want to participate. I want to continue my husband's work. And in fact, their whatever association they have, Ramtakis Association as an NGO, they are in fact continuing programs in prevention of sickle cell. Now we would like to request Dr. Jaya, Dr. Preeti. I met her in one of the conferences here in Hyderabad. She was explaining to me how her own child, who was a sickle cell warrior, how he encountered and how she could in fact take the help of prenatal allowance for the second child. We have live examples. May I now request Dr. Jaya Ramtekeji, Sampath Ramtekeji, please, Madam, you can express in Hindi, okay, whatever you feel about not what we discussed, general, whatever you want to share to our scientists and scholars.
नमस्कार सर, मेरा आवाज आ रहा है?
आ रहा है मैडम।
अच्छा सर, आज आपने यहाँ, मैं दिख नहीं रही ना सर?
No, बताइए आपका वो नहीं दिख रहा है। I have now closed my slide. If I have share your slide, can you share your slide, madam?
नहीं सर, मैं अपने मन की बात बोलूंगी सर, स्लाइड्स वगैरह।
बोलिए। And you can video is there ना मैडम?
हाँ,
you can join.
ये सब नहीं आ रहा है सर वीडियो, पता नहीं क्यों।
नहीं, वीडियो ऑन कीजिए, आप वीडियो ऑन कीजिए। अभी तो देख रहे थे
मैडम, आप
बंद
दिख
कर
रही
दिया
थी।
मैडम। हाँ, अभी ऑन कीजिए। हाँ, अभी दिख रहा है बस।
नमस्कार सब, आज सभी उपस्थित जो डिग्नेटरीज है उसके लिए मेरा नमस्कार सर। और आज राव साहब ने आज हमको यहाँ आने का चांस दिया है, इसके लिए बहुत धन्यवाद करती हूँ सर का। मैं जया संपत रामटेके की मिसेस हूँ, जिन्होंने 30 साल से सिकल सेल के काम आप सभी लोग जानते हैं, और उन्हीं के काम के और गवर्नमेंट ने रिकॉग्नाइज करके उनको 2018 में पद्मश्री सम्मान से गौरवान्वित किया। इसके लिए मैं भारत सरकार का भी बहुत धन्यवाद करती हूँ सर। और उनका जो कार्य है, अभी उनके इतना तो मैं नहीं कर सकती हूँ, लेकिन मैं ये सोचती हूँ कि थोड़ा बहुत जरूर प्रयास करना चाहिए, कि क्योंकि मैं भी एक सिकल सेल वॉरियर की माँ हूँ, तो सिकल सेल के क्या प्रॉब्लम्स है, क्या है, ये मैं भी जानती हूँ। और अभी हम लोग हाल ही में लोगों में जाके काम कर रहे हैं, तो बहुत से लोगों के क्या परेशानियां है और कितना हम मतलब उनके मन की भावनाएं भी जान सकते हैं सर। तो आज का जैसे विषय है सर कि भाई सिकल सेल के जो बच्चे हैं माने प्रिवेंशन हो रहा है या और भी मतलब इंक्रीज हो रहे हैं या डिक्रीज हो रहे हैं, तो मेरे अनुभव से मतलब हम लोग, मुझे ऐसा लगता है सर कि बच्चे अभी भी जन्म ले ही रहे हैं सिकल सेल के। यहाँ के अभी सभी मतलब गवर्नमेंट तो काम कर रही है सर उसके लिए, और कुछ एनजीओज भी काम कर रही है, और पेशेंट भी अभी अच्छे जो है वो पेशेंट भी अच्छे जी रहे हैं अच्छी तरह से, लेकिन फिर भी हमारे यहाँ बच्चे मतलब सिकल सेल के न्यू बच्चे जन्म ले रहे हैं। तो इसका कारण क्या हो सकता है, इसके लिए हम लोग क्या कर सकते हैं? इसके लिए तो सर सभी ने, आप लोग अभी तो साइंटिस्ट है सर, आप लोग सब जानते हैं, तो इस विषय में थोड़ा डिस्कशन करके जैसे आप उसके ऊपर क्या सॉल्यूशन निकल सकते हैं, इसके बारे में आप हमको समाधान दे सकते हैं। आज हमारा जो अनुभव है सर, जो हम लोगों में जाते हैं, तो उसमें अभी भी लोगों में सोशल स्टिग्मा जो है, जो लोगों के मन में है, वो अभी भी है। और अभी भी लोगों में काफी कुछ मतलब रूरल एरिया में बोलिए या ग्रामीण इलाकों में बोले, रिमोट एरिया बोले, अभी भी थोड़ी फार अवेयरनेस की जरूरत है, उनको एजुकेशन और काउंसलिंग की भी जरूरत है, क्योंकि जब भी उनको बताया जाता है तो एक तो उनके मन में डर रहता है कि भाई हमारे बच्चे को अगर हम बताएंगे सिकल सेल है तो हमारा समाज में क्या इम्पैक्ट पड़ेगा या हमारे बच्चों की शादी नहीं होगी। ये प्रॉब्लम अभी भी सर मतलब लोगों में है। तो ये इनकी मानसिकता को हम किस तरह से बदल सकते हैं, जो कि उनके मन में ये डर है कि सिकल सेल अगर हम लोगों में बताएंगे तो हमारे बच्चों की शादियां नहीं होंगी। और वैसे भी मतलब शादियों का प्रॉब्लम तो सर सिकल सेल बच्चों के लिए बहुत ही गंभीर समस्या है ये, क्योंकि उनकी शादियां नहीं होती है। आजकल सिकल सेल के बच्चे थोड़ा अच्छा जीवन जी रहे हैं और उसके कारण वो चाहते भी है कि हम आगे भी अपना जीवन थोड़ा अच्छे से जी सके। लेकिन ये मतलब उनके जो सामाजिक जो प्रॉब्लम्स आते हैं, इस वजह से उनको काफी परेशानियों का सामना करना पड़ता है सर। तो मेरा सब यही कहना है सर कि जो उनके मन में जो डर है या सोशल स्टिग्मा है, वो एक प्रकार से निकालना चाहिए और उनको थोड़ा अच्छी तरह से काउंसलिंग या एजुकेट करना चाहिए, ताकि उन लोग वो बात को समझ सके और आगे वो अपने आप को बच्चे मतलब ना बच्चा हो इस वजह से अवेयर हो सके। तो सबसे मुझे ऐसा लगता है सर, मैं बेसिकली मतलब देहात से हूँ। बेसिकली मतलब माय पेरेंट्स म्हणजे मेरे पेरेंट्स वगैरह देहात से थे, तो मैं बचपन मेरा थोड़ा कुछ दिन तक देहात में गया है। तो मुझे ऐसा लगता था कि पहले हमारे गांव में मलेरिया टेस्टिंग के लिए लोग आते थे सर, कि एक ब्लड लेते थे और सैंपल ले जाके जाते थे और उसके बाद में अगर किसी को मलेरिया है या फिर किसी को प्रॉब्लम है तो उनको गोलियां ला के देते थे और उनको काउंसलिंग करते थे, बताते थे कि भाई मच्छरदानी लगा के सो जाओ, मतलब मलेरिया नहीं होना चाहिए इस वजह से। तो मुझे ऐसा लगता है सर कि क्या सिकल सेल के लिए हम लोग ऐसे नहीं कर सकते हैं कि जाके वहां से ब्लड लेना और उनकी काउंसलिंग करना, उसको थोड़ा अवेयर करना इस बारे में, और उसको थोड़ा अच्छे से समझा के बताना, क्योंकि उनके लैंग्वेज में समझा के बताना पड़ेगा। क्योंकि अभी तो हम लोग सर जूम मीटिंग करते हैं तो हम लोग एक दूसरे से कनेक्ट है, लेकिन वहां तो जैसे ग्रामीण इलाकों में तो कोई नेटवर्क का इशू रहता है, उन लोग तो किसी से जुड़ते नहीं है, तो उनको तो वहां जाके ही सब चीज बताना पड़ेगा, क्योंकि वो भी ज्यादा इधर तो आ नहीं सकते। अगर आते हैं उनको तो हम बताएंगे, लेकिन हमको ज्यादा से ज्यादा उनके तरफ जाके हमको उनको समझाना पड़ेगा, ऐसा मुझे लगता है सर। मतलब मेरा एक मन की बात जो मैं हमारा अनुभव में बता रही हूँ सर। और दूसरी बात सर, हम लोग जैसे कि सिकल सेल बच्चे अगर रोकना चाहते हैं तो आप लोगों को सभी को ही मालूम है सर कि ये प्रीनेटल टेस्ट होना बहुत जरूरी है गर्भवती माताओं की। तो उसके लिए सर जैसे कि हमारे यहाँ रोशन कोला मैडम को मालूम होगा कि नागपुर में उन्होंने 3 पीसीआर मशीन दिए थे, मेडिकल के लिए, मेयो के लिए और डागा के लिए। लेकिन अभी की सिचुएशन ऐसी है सर कि अभी तीनों मशीन बंद है वो। हाँ, अब सिर्फ जो होता है टेस्टिंग वो सिर्फ दीप्ति जैन मैडम के प्रोजेक्ट के द्वारा होता है। तो ये प्रोजेक्ट तो सर 2-3 साल के लिए होता है, तो 2-3 साल करेंगे और उसके बाद में क्या उन लोगों का कहाँ टेस्टिंग करने जाएंगे। तो मुझे ऐसा लगता है कि वो गवर्नमेंट ऑफ इंडिया ने मतलब जो करते हैं उन्होंने परमानेंटली ऐसी कोई व्यवस्था करनी चाहिए कि यहाँ गर्भवती माता का सीरियस टेस्टिंग होना चाहिए, जिसके कारण अपन सिकल सेल मतलब बच्चे जो जन्म लेते हैं उसको हम रोक लगा सकते हैं। अभी हाल फिलहाल मैडम आईसीएमआर का तो यूनिट है चंद्रपुर में है, लेकिन अभी मैडम रोशन कोला मैडम वहाँ के मेंबर भी हैं। लेकिन बहुत सारे जो हमारे विदर्भ में जो लोग आते हैं, एमपी से भी आते हैं, छत्तीसगढ़ से भी आते हैं, बालाघाट, छिंदवाड़ा, तो वो उतना दूर चंद्रपुर नहीं जा सकते। तो इसकी वजह से नागपुर में उनकी सुविधा हो जाए तो उसके लिए, और ये हम बर्थ रोकने के लिए काफी कुछ मतलब हमारे लिए मतलब आगे वाले जनरेशन के लिए काफी फायदा होगा सर, ऐसा मुझे लगता है। तो इसमें संबंध में आप लोग तो ज्यादा जानकार है सर इस बारे में, तो इस बारे में थोड़ा सोच के हम रुग्ण के हित के लिए क्या कर सकते हैं, मतलब हमारे आगे सिकल सेल मुक्त हो इस जनरेशन के लिए हम लोग ने सोचना चाहिए। दूसरी बात सर ये है कि जैसे गांव के लोगों अभी भी मतलब थोड़ा आगे आ रहे हैं, थोड़े अवेयरनेस हो रहे हैं, है ना, तो वो टेस्टिंग करना चाहते हैं, क्योंकि गांव से भी हमको फोन करते हैं। मैं कई बार पेशेंट दीप्ति जैन मैडम के पास भेजती हूँ कि भाई मैडम के पास जाइए, वहाँ टेस्ट हो जाएगा करके। तो लोग थोड़े थोड़े अवेयर हो रहे हैं। तो इसके लिए अगर अपन लोग उसके लिए अगर सुविधा नहीं कर देंगे तो फिर वो बच्चे तो जन्म ही देंगे फिर वैसे। क्योंकि अभी भी एक पेशेंट अभी हमारे पास आया था, उनको टेस्ट करना था, और वो यहाँ नागपुर में मेयो में गवर्नमेंट में एक फैसिलिटीज थी कि वो मैडम चेक करती थी, तो वो मैडम का ट्रांसफर हो गया, अभी वो मैडम यहाँ करती नहीं है। मतलब हमारे नागपुर में अभी सिर्फ दीप्ति जैन मैडम के पास जो प्रोजेक्ट है उसी के अंतर्गत में सीवीएस की टेस्टिंग होती है, अदरवाइज बाकी जगह होती है। तो यहाँ जो हमारे यहाँ मशीन दिए थे सर, तो उसके लिए अगर गवर्नमेंट उसको किसी को ट्रेनिंग देके, उसको एक्सपर्ट को ट्रेनिंग देके, एक्सपर्ट करके उनको यहाँ भेज के ये सुविधा यहाँ परमानेंट होनी चाहिए, ऐसी हमारे एक सोसाइटी के तरफ से भी एक इच्छा है सर, ताकि हम लोग उसको प्रिवेंट कर सके सिकल सेल के बच्चों के लिए। दूसरी बात, ऐसा मुझे लगता है अभी केंद्र सरकार ने अभी 200 करोड़ का अभी सिकल सेल के लिए ये किया है, मतलब प्रिवेंशन के लिए दिया है सर ने, गवर्नमेंट ने, और उसके लिए तो ठीक है सर, प्रिवेंशन के लिए दिया है, लेकिन अभी जो हयात जो स्टूडेंट मतलब पेशेंट्स है, कोई प्रोविजन हमको नहीं दिख रहा है। मतलब ऐसा तो कुछ बताया नहीं गया है, अभी पता नहीं इम्प्लीमेंटेशन होगा उसके बाद में अगर उनके लिए भी प्रोविजन है या प्रिवेंशन के लिए भी प्रोविजन है तो समझ में आ जाएगा। पर हाल फिलहाल तो अभी ऐसे लग रहा था कि अभी सिर्फ प्रिवेंशन के लिए ही मतलब प्रोविजन है, और अभी जो हयात रुग्ण है उसके लिए क्या प्रोविजन है ये अभी हमको पता नहीं चल रहा है सर, इसके बारे में, है ना। तो हमको यही लग रहा था कि भाई पेशेंट के लिए भी कोई रोजगार की व्यवस्था होनी चाहिए, क्योंकि अभी हाल फिलहाल ये प्रॉब्लम है सर कि ना तो उनकी शादियां होती है और ना ही उनके पास कोई अच्छा स्ट्रांग रोजगार रहता है। आज हमने उनको दिव्यांग में शामिल किए हैं, 2016 में उनको दिव्यांग में शामिल किया है, लेकिन अभी भी सर उनके लिए जो यूडीआईडी कार्ड होना चाहिए वो परमानेंट नहीं मिल रही है, क्योंकि केंद्र सरकार ने जो भी उनके लिए शर्तें दी है, उसमें जो क्राइटेरिया दिया है, तो उस क्राइटेरिया के हिसाब से अभी उनको नहीं मिल रहा है, क्योंकि उनका कहना है कि साल में 3 बार होना चाहिए, साल में ब्लड डॉक्टर्स ने जो हाइड्रोक्सोरिया गोली दी है, इस वजह से काफी बच्चों में ऐसा मतलब सुधार आया है कि उनको ज्यादा हॉस्पिटलाइज होने की नौबत नहीं आती है। तो फिर ये क्राइटेरिया लागू नहीं होता है तो उनको यूडीआईडी कार्ड भी नहीं मिलता है, और यूडीआईडी कार्ड नहीं मिलता है तो उनको कोई रोजगार के लिए कोई आरक्षण, ना गवर्नमेंट के लिए ना प्राइवेट के लिए कोई आरक्षण नहीं है। तो उसके रोजगार के हिसाब से भी गवर्नमेंट ऑफ इंडिया ने कुछ तो भी उनके लिए करना चाहिए। ऐसे में ये मेरा सोसाइटी की तरफ से एक रिक्वेस्ट है, जो आप साइंटिस्ट और विचारवंत हैं तो इसके ऊपर कुछ तो भी हल निकाल सकते हैं इसके बारे में, है ना। और जो भी अभी उन्होंने जो क्राइटेरिया रखा है उसकी अगर कोई जो शर्त है या कुछ ये है वो थोड़ा अगर शिथिल कर दे, मतलब थोड़ा कम कर दे, जो कि उनके लिए यूडीआईडी कार्ड मिलने के लिए थोड़ा कठिनाई ना हो। तो इस विषय में भी थोड़ा अगर कोई, मैं अभी अगर रामटेके साहब रहते तो वो शायद अभी तक के उनके लिए कुछ ना कुछ प्रोविजन करते, पर अभी मैं अकेली मैं उतना गवर्नमेंट से नहीं उतना ये कर सकती। तो मैं यही बता सकती कि आप लोग जो साइंटिस्ट और आप लोग जो इतना काम करते हैं सिकल सेल के लिए, तो मतलब उसके हिसाब से अगर आप उनके बोलते हैं, जैसे आज विनीता श्रीवास्तव मैडम है यहाँ शायद उपस्थित, तो ये बात हमने विनीता श्रीवास्तव मैडम से पिछले बार भी जूम मीटिंग में मैंने कहा था, मतलब हमारी बातचीत हो गई थी इस बारे में। अभी तो वो सिर्फ 3 साल के लिए दिया है, लेकिन हमारा ये कहना है कि उनको सिकल सेल का बच्चा सर परमानेंट उनको मिलना चाहिए, क्योंकि उनका कभी कुछ क्या हो जाएगा कुछ कह नहीं सकते हैं। कभी अभी तो इतने बच्चे हिप जॉइंट के कारण इतने लंगड़ के चलते कि उसको पहले से पता चल जाता है कि उसको एवियन का प्रॉब्लम है, उसको मतलब ऐसे हो गए हैं।
जया मैडम, यहाँ पे मैं ये बोलना चाहूंगी, सॉरी आपको इंटरप्ट कर रही हूँ, कि ये डिसेबिलिटी का प्रॉब्लम सॉल्व हो गया है। हर बच्चा जिसके पास एसएस का कार्ड है उसको 40% डिसेबिलिटी मिलने वाली, वो चेंज करवा ली हमने, तो वो आ जाएगा प्रैक्टिस में थोड़े दिन में, वो इश्यू परमानेंट मिलेगा वो कार्ड। तो वो इश्यू अब अपन थोड़ी देर रुक जाइए, वो आ जाएगा प्रैक्टिस में।
मैडम इतना ही है कि 40% डिसेबिलिटी में कुछ एडवांटेज नहीं मिलता है।
नहीं सुनिए, वो सब हुआ डॉक्टर पटेल, वो हम बाद में बात कर सकते हैं। वी हैव डन एवरीथिंग, पूरा वो क्राइटेरिया निकाल दिए, एवरीथिंग हैज चेंज्ड एंड आई
It should be 100% disability given to the patient of.
अरे डॉक्टर ज्योतिष, if we give 100%, where will they go? उनको कौन मेडिकल में लेने वाला है, कौन वो करने वाला है?
There is a need of special thinking on this issue because disability 40%.
It has been ज्योतिष पटेल सर, अच्छी कमिटी थी एंड 2 साल ये डिस्कशन हुआ क्योंकि आई वॉज द वन सिकल पेशेंट्स को जो नहीं मिल रहा था परसेंटेज, एंड नाउ आई हैव सीन बिकॉज दे आर आर पेशेंट्स है ना कि दे विल गेट द मैक्सिमम बेनिफिट, दे विल. I think we need not discuss this here, but it is now coming up. That's all I want to tell.
At least advantage should go to them.
Yeah, madam.
It will be. Yeah.
Yeah, madam.
sir.
I'm Dr. Italia from Valsad, Gujarat.
Okay, sir.
राम तेके साहब हमारे वहाँ गुजरात में भी आए थे.
हाँ सर.
मैंने अभी जो फोटो बताया उसमें भी वो थे. डॉक्टर ग्रेहम सार्जेंट और डॉक्टर काटे साहब के साथ.
हाँ सर.
Lot of work he has done for the country. मैं आपको ये बताना चाहता हूँ कि आपने जो क्वेश्चंस अभी रेज किए, ऑलमोस्ट वी हैव सॉल्व्ड इन गुजरात और वी आर ट्राइंग टू सॉल्व इन गुजरात एट द मोमेंट. पहली बात तो ये थी कि जब भी हमने गुजरात में ये प्रोग्राम शुरू किया तब ये जियो एनजीओ पार्टनरशिप में शुरू किया था. वलसाड रक्तदान केंद्र वाज वर्किंग सिंस 1984 ऑन सिकल सेल प्रोग्राम्स. So government has nominated us to implement the program in government services, and that we have done between 2006 to 2012. और 2012 में गुजरात सिकल सेल सोसाइटी बनाया, हाँ, एंड हमने हमारा काम बंद कर दिया. तो we were no more nodal agency for the government of Gujarat since 2012. So from 2006 to 2012 we have done our all work. एंड दूसरी बात ये थी कि गांव में जाके हमने सबका घर घर जाके उनके घर से हमने ब्लड सैंपल कलेक्ट किया है और फिर बाद में डीडीटी टेस्ट किया और जो पॉजिटिव आया उसका एचपीएलसी टेस्ट लैब में लाके किया. सो वी हैव गॉन अप टू द doorstep of a tribal person at their own house. Second thing, we have made an arrangement कि उनको जो दवा मिलनी चाहिए वो दवा वो प्राइमरी हेल्थ सेंटर से सीएचसी से ले सके, और नहीं भी जाते तो मल्टीपर्पज हेल्थ वर्कर विल गो टू देयर हाउस and will provide them the medicine. He will give the medicine and will take up the empty foil back क्या उसने पूरा महीना दवा लिया है कि नहीं लिया है. So all this type of facilities are being we have started and we are continuing with that. And because of all these things, Government of India in 2011, Dr. Manmohan Singh has given us Prime Minister's Award to the Gujarat government. That award was to give better facility to the to tribal people, which is going to benefit large number of tribal population in India. And after that award, it has become something like a Gujarat model for all other states. So all this treatment is being given. Hydroxyurea is given. In the program, we have written that hydroxyurea should be available uninterruptedly. हाँ, उसके अंदर बंद नहीं होना चाहिए. अगर कोई जगह पे नहीं मिलती है और हमको मालूम पड़ता है तो we inform the government, then government will see that everything is done within short time. So all this type of things are going on. One has to take advantage. People has to take advantage what government facilities giving them. Prenatal diagnosis. All prenatal patients in tribal areas screened for sickle. If positive, their husbands are screened, and if positive, that high-risk couple is subjected to counseling, and if ready for prenatal diagnosis, we go for prenatal diagnosis. But prenatal diagnosis is, we will go for prenatal diagnosis only if that lady is ready for MTP, medical termination of pregnancy, if the child is going to be homozygous or double heterozygous. So In that case only we will go for prenatal diagnosis. Second thing.
Dr. Italia, just one point about this. It's ethically wrong that you cannot say that you will only do prenatal diagnosis if they are going to terminate the pregnancy. Prenatal diagnosis has to be offered if they want it done. And
Yes.
it's up to the couple
You cannot
eventually
make it
whether they want to
compulsory.
terminate or not.
Yeah,
Yes, I understand that, but there is no point or no point in going for if they are not going for MTP. So we have
you
to.
cannot make it compulsory.
That is not correct.
You cannot make it.
Yes. There are many.
You know, you cannot interfere into somebody else's life, sir.
Absolutely.
Those people will have to
fully
take a
agree with
decision,
you.
not we.
Yeah,
Not even for the marriage for that matter.
Even whatever prenatal diagnosis we have done, hardly 70% has gone for MTP.
Yeah.
Others have not gone for MTP. So
Yeah, with all due respect to Dr. Italia, let me tell you that, you know, we are on the international forum and this is recorded and there are international dignitaries who are on the dais. Let me tell you that we are trying to put a rosy picture. Let me tell you, even the Gujarat has got a screening test and the HPLC report comes after, you know, many months. Let it be a reality. Let this, that it has to be a transparent. Dr. Rao is sitting here. Dr. Other from US are also sitting here talking about the hydroxyurea. I had been to Chota Udeipur recently and 70% of the patients, they do not have hydroxyurea. What I am trying to tell you that, see, when we have to have a realistic attitude when we are formulating, you know, the policy for the government of India. Let us be realistic. We should not never tell something which is, you know, not existing in the system. On paper it is fine, but at the same time, at the delivery point, there are so many things which needs rectification. And this is only my submission. Thank you.
Dr. Jyotish Patel.
Could we please, could we please, you know,
Yes,
hear from Dr. Preeti Nagarare, please?
Yes, please. Yes, yes.
Dr. Rao, can I say one?
Yes, Dr.
Yeah.
Mukherjee.
No, I am surprised that Dr. Italia is talking about Gujarat
Hello?
model. Hello, can you hear me?
Am I audible?
Preeti, 1 minute, 1 minute,
Yes.
Preeti.
Hello?
Okay.
Preeti,
1
1
minute,
minute.
1 minute, 1 minute. What I am telling is that Dr. Italia is telling that Gujarat model, and I am surprised that only 60 to 70% are accepting the prenatal diagnosis. On the contrary, what we are doing in Chandrapur or Gadchiroli, those undeveloped or the rural area, it is almost 95% are acceptable. So I don't know the reality.
Agree with Mukherjee, agree with him, because all my patients now are from interior, Gadchiroli, Chandrapur,
That's what I'm
Bandara.
telling. We are working in
90% of
Chandrapur,
my patients are
Gadchiroli.
from
I can give you the number. I can give you the number. But it is very surprising that Gujarat is a progressive state and that is the model that government of India is following. But other side, it is not accepting. That is also very surprised.
Yeah.
Dr.
Many
accepted.
career,
Dr. Urade and others. See,
Yeah.
we all accept, you know, what with your own experiences you are telling, you know. But what is important is, tell me any other place, even Dr. Jaya, that Mrs. Ramteke was asking, institutional arrangement, you know, what we have in Gujarat, where impact is different thing, but arrangements, institutional arrangements, that we don't have any other part of the country. What GO, NGO, okay, we don't have. That has to be created as a mandate, you know. Now the question of impact, even Gujarat, even Maharashtra, wherever, we would like to have a third party impact evaluation.
Sure.
That is what recommendation.
Yeah.
It's not subjective, no. We will, third party will go and evaluate.
Absolutely.
Impact. That is
Yeah.
what our recommendation. Now
Sure.
let us, regarding Mrs. Jaya, madam,
sir.
we have raised a very important issues at a practical local level, and this video is recorded. We will put your whatever, you know, discussion you have put in forth in terms of, you know, what are your issues. That is going to be put, you know, in verbatim, and we will send this to all the ministries who are dealing with it. Okay.
Yeah.
Okay.
So from that point of view, this forum is going to take some action in terms of recommendations and whatever observations by the mothers of the warriors. They are the people there. I am still surprised. I am not surprised, of course. Stigmatization. Stigmatization is one issue. We have only addressing it. Stigmatization means society has to be educated. We do massive screening programs and educate the student, and the student forgets by the time he becomes adults. It is not that. It has to be a continuous process, in terms of educating and evaluating their knowledge and practice. Okay. This type of whatever Dr. Italia was telling, that screening, okay, it is for anemia screening, but you know the results of the sickle cell positive negative. Why to distribute to the students? There is going to be stigmatization. There are going to be, even Chhattisgarh, we came to know, there are definitely cultural issues bound to be there. So this, whatever your remarks, madam, it will be documented, and others' feelings, whatever feedback has come. Okay. And what is important is harmonizing the total effort. It is not that Gujarat is one model and other places are one model. Nagpur, Maharashtra, I know that how the government vertical model is working there. Yes, you people are doing it best. Ramteke could have brought that difference. Okay, but I am sure with your efforts, you also can make a difference. Making a difference is possible also. Okay, with this, madam,
one thing
Dr. Urade, we are going to.
I would like to.
No, Dr. Urade, we are going to for Dr. Preeti, Mr. Mrs.
Just 1 second, sir. 1 second.
No.
There should be
No
bone
time.
marrow transplantation.
No,
facility should be
don't
there.
bring all that. Don't bring about clinical management. There are issues. What our Patel, Dr. Patel, other people are discussing. There is no uniform guidelines for clinical management. Okay, that will come later. Urade, please. Next comes.
थैंक यू सर, आपने मुझे आज यहाँ बोलने का मौका दिया है, उसके लिए मैं आपका बहुत बहुत शुक्रगुजार हूँ.
We are very thankful for you, madam. You have come and participated here. Mrs. Preeti, thank you. Mrs. Preeti, please.
Where is she?
Preeti Nagarale. Is she there? Mrs. Preeti Nagarale.
I think it's frozen. Yeah.
Yes.
Dr. Preeti, could you please go ahead?
Yes.
Others can mute. Yeah.
Hello. Am I audible?
Yeah, Preeti, please. Please, madam.
I'm feeling so little here that all dignitaries and panelists are so knowledgeable and working from since many years. First of all, good evening to all dignitaries, panelists, government authorities, and government NGO representatives present here. A very big thanks for inviting me, and many congratulations for organizing committee. My name is Preeti Nagrare from Nagpur. I'm working at Government Medical College. But I want to correct you, sir, that I am not a doctor. I am very little here. As you introduced me as a mother of warrior, my sickle cell genotype is I am sickle cell bred. My story begins when my daughter diagnosed with sickle cell anemia at the age of 3. Now she is 18 years old, younger. With no hospitalization and no bleeding. And when she diagnosed with sickle cell anemia, I took her to Dr. Jene ma'am. Ma'am taught me to life management in sickle cell anemia. I follow her. At that time, Dr. Jene ma'am gave me the knowledge about prenatal diagnosis. And I planned second pregnancy. Dr. Jene sent me to the ICMR Mumbai. That time Dr. Kola was there. And after PND, I got the report of absence of sickle cell gene in my second child. I continue my pregnancy and I am having a normal child right now. I was very happy that time and my family too. And that day I decided to do. So my angel, that time my angel was Dr. Jene, and I wanted to be angel for others. So I started advocating for sickle cell anemia. That time I met with my guru, my sickle cell guru, Mr. Sampatji Rampeke. Everyone knows he is awarded for his work, Padmashri awarded. He said only two things should be do. The quality for sickle cell warriors and comprehensive care and prevention of sickle cell anemia. Am I audible, sir?
Yes, you are audible.
Okay. For that, there is a need of universal screening. The screenings should be mandatory for school, colleges to cover all the ages. The prenatal screening and counseling, some people said no for this. Some would not like to screen before marriage. There are controversies, as Dr. Italia said, but there is a second way, that antenatal screening, but especially I insist for couples staying there, because there are many combinations with sickle. To catch them, partner should be screened, and antenatal screening should be mandatory, and gynecologists play their vital role. So the antenatal screening should be at the first 3 trimesters. Everyone knows here, but I would like to say that mostly pregnant lady came after 3 months of pregnancy. So sometimes because of late visit to the clinic, they gave birth to the sickle cell baby. So to catch that baby, there should be neonatal screening, and neonatal screening, and the screening should be mandatory by HPLC test. I would request for the HPLC test, because sometimes the solubility test or electrophoresis test may not give the combinations. Electrophoresis test will not give the combinations, but HPLC should be there. It should be mandatory in primary health centers and district level hospitals, and mobile van should be there for the tribal regions. Labor groups are there. Many under poverty peoples are in labor groups. They cannot afford to travel and treatment. So for that, the treatment should be into their steps, their steps. Because of the lacking of treatment, there leads to the mortality, and the negligence about the health. Actually, all the facilities should be under one roof, I think. It should be under one program, like national program, which will give the service for prevention of thalassemia and sickle cell by universal screening. The counseling and proper treatment, and treatment with guidelines. Nowadays, we know that Union Minister Dr. Bharti Pawar ma'am releases the standard treatment guidelines for sickle cell anemia disease, which was made by ICMR. I will congratulate them for doing such a nice work. And Government of India also giving the mission to eliminate sickle cell disease by 2047. In that, Ministry of Tribals also playing a very important role, and Ministry of Health is very dedicatedly working. So we are very thankful to them. Now I can say that one day it's not far away when we would say we are free from this genetic disease. This is a big challenge for tackling stigma and socio-cultural challenges faced by sickle cell warriors, especially women with sickle cell disease. So social taboos are there. Many social taboos are there. To get rid of this, we should take awareness programs. And as Patel sir said, that the adult sickle cell management should be improved. In healthcare management should be improved. So other adult sickle cell management should be improved. I'm totally agree with Dr. Jyotish Patel that I am literally at Government Medical College Nagpur. I am looking at this problem because pediatrics there is less mortality within pediatrics, but there is more mortality within adult patients. And actually, I think this is a socio psychological problems also. So there should be a psychosocial counseling programs for them, for the sickle cell patients, adult sickle cell patients. So the challenge is bigger, but we have to take that challenge. And national registry, like Rao sir said, that we everyone having the Aadhaar card, like that we should register for the sickle cell status. So that concept I like. And sir said that we are not getting the data. We are not getting that sickle cell disease is increasing or decreasing. We are not getting that much data, and that's why the we should go for this screening, universal screening, and registry, national registry. So I like that use geo NGO model. I like that concepts of, and I would like to recommend that concept in Maharashtra also. So the nowadays we are screening by our NGO. We are taking screening programs. We are giving them reports, and with reports we are counseling them. Suspect screening, as I told to Dr. Rao, that we are doing cascade screening too. So one request for my one request is my for government. The government should aware people by using social media, printing media, by movies, by documentaries and advertisements on TV, radio, by well-known persons like sports person or actors in their local languages, so that that awareness will be more powerful. I think. Now I am working with Sickle Cell Society of India since 15 years with Sampath Ram Tekiji, and I am continuing with Jayaram Tekiji. With the aim of spreading and preventing this genetic disorder, betterment of patients' life, and to get government facility on tertiary level, so that their life will be improved. That's all. And thank you for giving me opportunity to express myself. Thank you very much.
Thank you, Preeti, for your interaction. Thank you very much. Whatever is said is well taken. All will be recorded, and we'll be communicating to all whoever the concerns, different agencies. Okay. Thank you very much for participating. And now, Professor Duggirala.
Sir, vote of thanks by Dr. Gadde. Gadde, and our two-hour program has become now 3-hour long program.
Yes,
that's good. We have a wonderful discussion. Yes, sir.
Yeah.
Dr. Gadde, vote of thanks.
Yes, sir. Yes, sir. Thank you. I take this opportunity to express my deep gratitude and thankfulness to all the experts and panelists, which consists of administrators, clinicians, sickle cell NGO representatives, and scientists, and anthropologists, and mothers of sickle cell warriors. I see exemplary, committed professionals here, and for each and every one, we express our gratitude for bringing your experiences and insights and wisdom and pragmatic solutions and suggestions and scientific observations, and we look forward to share this on this World Applied Anthropology platform to share as our country experience, to learn from other country experiences to address this global public health issue. So harnessing all these energies and experiences and ground level experimentations and success stories, and for all this, we are very much thankful. We are filled with gratitude. For organizers, starting with this kind of panel, I'm particularly thankful to Professor V.R. Rao sir for organizing such a wonderful experts and who has decades of experience working with a passion and a commitment to fellow people, humans on this in the local societies and local surroundings. So this sends a great message to for the process of nation building. So I'm for administrators, Dr. Vinita Srivastava, Madam, Advisor, Tribal Health Affairs, Government of India, and Sri D.N. Murty, sir, former Advisor, Tribal Welfare Department of Andhra Pradesh, and the clinicians, Professor Graham or Serjeant, sir, former Director, MRC Laboratories, University of West Indies, and Professor Pradeep Kumar Patra, sir, Dean of Chandulal Chandrakar Memorial Government Medical College, Durg, Raipur, Madhya Pradesh, and Professor Deepti Jain, Madam, former Professor and Head Department of Pediatrics, GMC Nagpur, Medical Officer, and Sickle Cell NGO representatives, Dr. Suman Jain, Madam, Thalassemia and Sickle Cell Society, Hyderabad, and Dr. J.S. Arora, sir, National Thalassemia Welfare Society, Delhi, and Dr. Nanda Kumar Menon, sir, Ashwini Kudalur Adivasi Hospital, Gudalur, Nilgiris, Tamil Nadu, and Dr. S.D. Italia, sir, ex-honorable director, GEO NGO, Sickle Cell Anemia Control Program, Government of Gujarat, and Dr. Jyotish Patel, sir, Super Specialty Hospital for Sickle Cell and South Gujarat, and Dr. Kapil Dev, sir, Seva Rural Hospital, Jagadish Baru, Gujarat. So, and also I express my deep gratitude to scientists, Dr. Roshan Kola, Madam, former scientist, G, and Director in charge, ICMR, National Institute of Immunology, Immunohematology, and the other scientists, Dr. M.B. Mukherjee, sir, former scientist, consultant, ICMR, National Institute of Immunohematology, Mumbai, and fellow anthropology professor K.N. Saraswati, Madam, Professor, Department of Anthropology, Delhi University, and Dr. Bhaskar Urade, Superintendent Anthropologist, Anthropological Survey of India, Kolkata. So I and also express my deep gratitude to mothers of sickle cell warriors for their sharing their experiences and giving a practical suggestions for the policy considerations and thought-provoking experiences. So for Mrs. Jaya Sampath Ramtake, Madam, Sickle Cells from Sickle Cell Society of India, Nagpur, and Mrs. Preeti Nagarare, from Sickle Cell advocate, who is a sickle cell advocate working with Sickle Cell Society of India since 15 years. So for all these wonderful, noble personalities, From our bottom of the heart, we express our deep gratitude on behalf of the organizing committee. And we thank you so much for your commitment, for your efforts, for making the positive difference for the patients. And also we look forward for harnessing all these energies, experiences, wisdoms, and success stories to come up with policy recommendations and elsewhere, not only in India, but elsewhere in the world. So I strongly believe that this will send a great message. And thank you for your valuable, committed, long-standing contributions at the individual, at the community level, at the hospital level, at the NGO level, and addressing this huge problem in India, which is a very highly responsible job. And you provide the inspiration and direction, and with all these things, coupled with the anthropological perspectives and knowledge, and we want to see what can be done in most excellent ways looking forward. Thank you so much. Thank you all. The dialogue begins, and we will continue. Thank you so much. Thank you.
You all. Nice meeting you, Dr. Rao Garu. Thank you so much for inviting me to this, and it's great meeting you all. Thank you. All the best with the programs.
Sir, I thank our Governing Council committee member and the key person in organizing this World Congress, Professor Ravindranath Duggirala, sir. He is the main person.
It's okay. It's okay.
And thank you so much, sir. Thank you.
Yeah.
Thank you.
Bye-bye.
Bye-bye.
Bye-bye. Bye-bye.
Thank
Bye-bye.
you.
Thank
Thank
you,
you
sir.
very
Thank
much.
you.
Bye-bye, everybody. Good night.
Bye-bye. Bye-bye. Thank you.
Bye.
Good night. Good night.
It's a wonderful, nice meeting you all.
Bye.
It's amazing,
Nice
amazing
meeting you all.
experience, you know.
Right, right.
Duggirala, sir.
So, ma'am,
I
how are
just
you?
want, I would like to talk to you a bit later. I'm also
Yes,
working
yes.
on cardiovascular diseases, especially on global DNA methylation, epigenetics and genetics.
Oh, that's
So-
wonderful, you know. I would love to talk to you, and one of these days I will arrange a Zoom call, you know.
Please, sir,
If you're
please,
available, and we can
we'll
talk.
have a discussion. Yeah, thank you.
Sure. Thank you.
Thank you, Dr. Rao.
Thanks. Thank you.
Bye-bye, Dr. Italia. Thank you.
Bye-bye.
Thank you.
Bye-bye.
Bye-bye.
Thank you all.
Bye-bye, Dr.
Thank you all.
Preeti,
Thank you all.
Dr. Murty, Dr.
Bye.
Jaya,
Take care.
Dr. Bye-bye.
Bye.
Thank you all. Thank you so much.
Dr. Ravindranath, thank you.
Yeah,
Well.
Dr. Rao Garu, it's amazing. Namaste, Amma. Namaste, Dr. Jaya Garu. It's an amazing experience.
आप लोगों
It's
से
wonderful, sir. It's wonderful.
नॉलेज मिल गया है, आपके साथ में जुड़ने के बाद में काफी नॉलेज मिल गया है, और ऐसा ही हमेशा आप मार्गदर्शन करते रहिए ताकि हम लोगों में जाके और काम कर सके। थैंक यू सर, थैंक यू सो मच।
Thank you, madam.
Thank you so much.
Thank you. Bye-bye. Bye-bye.